5, 4, 3, 2, 1. And we'll end.
Good morning, everyone. We welcome you all to OrthoTV in association with Maharashtra Orthopaedic Association. This is the first of the Veteran Surgeons Forum. Webinar. To introduce today's webinar, I hand over to our president, Dr. Wasudeo Gadegone.
My screen is visible?
Yes, sir. Yes.
So, Maharashtra Orthopaedic Association, greetings from. Good morning, everybody. We are on the second session of this Veteran Surgeon Forum Masterclass. It is our endeavor to get some instructions and knowledge from a very experienced people, and therefore we have formed a Veteran Surgeon Forum. Our motto is sharpen the surgical rationale and improve the patient outcomes. I welcome you all members of Maharashtra Orthopaedic Association and viewers of OrthoTV to this a very prestigious webinar on compartment syndrome, Veteran Surgeon Forum organized by Maharashtra Orthopaedic Association. And we have a galaxy of eminent faculties, Dr. Vikas Agashe, Sangeet Gawhale, R.M. Chandak, Parag Lad, Mandar Agashe, Girish Motwani, and Venugopal Sambharam. To introduce our guest, I hand over mic to Dr. Rajendra Abhayankar, our convener of this a prestigious webinar. Over to Dr. Rajendra Abhayankar.
Thank you, sir, and good morning, all. These galaxy of the speakers, they do not need an introduction, at least in Maharashtra, but I will just enumerate them. One is Dr. Vikas Agashe, who is a senior orthopedic surgeon from Mumbai and is well known for his work in infection, and especially we know him as a calcaneum person in Kolhapur. The next is Dr. Sangeet Gawhale, who is also at present president of the Bombay Orthopedic Society, a senior orthopedic surgeon. Next is Dr. Parag Lad, who is a hand surgeon from Thane, a very senior and enthusiastic colleague. Next is Dr. Girish Motwani, who by age or looks doesn't look a veteran, but is a veteran in his work. And so is Dr. Mandar Agashe. By age, he may not be a veteran, but his work speaks a volume. We have Venugopal Sambharam from Solapur, who will be presenting the cases. And last but not the least, Dr. Rajendra Chandak, who I always look towards for having new things. And he teaches to everybody who calls for it. With this, I hand over back to Dr. Gadegone, sir.
Thank you, Abhayankar sir, for your nice introduction. Now I request Dr. Sangeet Gawhale, our moderator of this webinar, to conduct the further proceedings. Thank you, sir.
Good morning and welcome, all of you. So this is the second Veteran Surgeons Forum, and we plan to have it every month for the coming year. And we will be choosing topics which have not been covered so far, which are interesting and useful to you in your common practice. And we'll try to give as much information possible regarding that particular topic. Besides that, MOA is conducting various activities throughout the month in the form of Young Surgeons Forum, which is also held every month, and something related to your clinical practice would also be started every month from the next month. So with this, I thank Dr. Gadegone sir, Dr. Abhayankar sir for taking this initiative in starting with these programs for all the members of Maharashtra Orthopaedic Association. So we come back to our topic, today's topic, and we have excellent faculty who are specialists in that particular field, who have taken a lot of efforts for making this presentation. I thank all of them for giving us time, and you have taken time for preparing that lecture and giving information to all the members of Maharashtra. So with this, Dr. Agashe sir, are you ready?
Yes, he has joined.
He's not seen.
I think there is some issue with his audio. I think we can go to the next and then.
Right. So we can start with Dr. Rajendra Abhayankar on his talk on compartment syndrome. Can you share your screen, sir?
Rajendra Chandak.
Sorry, I'm sorry, Rajendra Chandak.
Yeah. Good morning, dear friends. We'll be discussing today compartment syndrome. So my task is management of compartment syndrome. Compartment syndrome, as we know, is an elevation of the interstitial pressure in a closed osteofacial compartment that results in microvascular compromise. And therefore, we release the facial compartments. I hope my screen is visible and audio is okay.
Yes, sir. Perfect.
So in a compartment syndrome, what happens is the muscles, the veins, nerves, all the constituents get compressed, and there is a critical increase in the pressure in a closed muscle compartment, and therefore release as widely, including all septa. This has potential to irreversible damage for muscle tissue, nerves, and blood vessels, and therefore early decompression is warranted. Compartment syndrome is a true orthopedic emergency. It leads to, we have to immediately recognize and do a treatment by fasciotomy, which would save limb and the function to the limb. A late diagnosis or an inadequate treatment leads to irreversible changes. Whenever compartment syndrome is associated with vascular injury, angiography is mandatory, maybe CT angio or regular angiography. It may locate the site of injury to the vessel, characterizes the injury, defines the status of vessel proximal and distal, and may afford therapeutic intervention by vascular intervention surgeons. It's a common experience whenever we have a compartment release. So immediately the pain, the compartment syndrome clinical setting is characterized by pain, and pain. Immediately as soon as we release the compartment, the pain goes away. It's a great relief to the whole team. So paresthesias decrease, the woody heart swelling goes away, and pain diminishes. It's a very rewarding surgery. I would emphasize that all the team members in our institution or in the setting, clinical setting, we should teach the feel of the compartment syndrome. Compartment syndrome is more of a clinical diagnosis corroborated by investigation if needed, and all the staff should be able to feel the tissue tension and the tightness of compartment. This is important because many times this compartment syndrome land up with a very odd time, and if every one of the team member is aware of the condition, then you will be called early to salvage the limb. I would just initiate the management, and before any surgery or at the time of clinical evaluation, I would just go ahead with a handheld Doppler, ascertain the circulation, etc. The compartment pressure measurement just before surgery, I usually do it every time whenever I am releasing a compartment syndrome. Number one, the diagnosis is clinical. Still, measurement is useful in certain clinical setting, like in unconscious patients with in ICU, etc. So measuring compartment syndrome is useful, and we must gain some more experience into it. The devices for measurement are usually not available in India, and the most useful clinical bedside method is a Whiteside's method. And in theater, it becomes easy and it's not difficult at all. You need to gain some more experience before it becomes really reliable for you. A simple device for measurement is it requires 18 gauge needle, which is inserted into the muscle compartment. a mercury BP apparatus, and a venoline cannula. The needle is inserted, and the amount of pressure required to inject a small amount into the compartment is what gives us the compartment pressure. And we see it by the movement of the air column. So you have an air column, and when we move this, the air column moves with the injection of the air in this syringe or saline. So this is what we are injecting. And then you look towards the air column. When it gets displaced, that is the amount of pressure required. And in this patient, when it was done, it was 140, very raised compartment pressure. Dermatophysiotomy is the only treatment for a confirmed, strongly suspected muscle compartment syndrome. It is essential to perform this as an emergency procedure, and certainly no later than 6 to 12 hours from the onset of condition. Basically, as soon as possible, it is a true surgical emergency. Our treatment goals are immediate and sufficient oxygenation to the cell by decompression of release of muscle, skin, fascia, everything. In the leg, there are 3 approaches: bifibulectomy, single incision perifibular fasciotomy, and double incision fasciotomy. The double incision technique is safer and more effective, and generally I use it. A single incision from just distal to the head of the fibula to 3 to 4 centimeter proximal to the lateral malleolus. Perform a longitudinal fasciotomy of the anterior and lateral compartment. Avoid injuring the superficial peroneal nerve in the lower third part of the wound. Undermine the skin, raise flaps, decompress anteriorly and laterally, subperiosteally dissect the flexor hallucis from the fibula, and go to the deep posterior compartment and the superficial posterior compartment. These are the 4 compartments of the leg: the anterior, the lateral, the deep posterior, and superficial posterior. In the single incision technique, this is the classical incision all along fibula, and this is what we aim at decompression. We, alongside the tibia, we decompress the anterior compartment and the lateral compartment, and by raising posteriorly, we decompress the deep and the superficial posterior compartment. A double incision technique gives a more thorough decompression of the deeper compartments. So how it is done? On the lateral side is the standard single incision. On the medial side, an incision which is developed proximally into superficial posterior fasciotomy and the deep posterior fasciotomy. So we enter all the 4 compartments. This is how the deep compartment is released. Have a clear concept for decompression. See, once you give incision, so anterior compartment, if your incision is here, you also have to go laterally and release all the septa as well as deep and superficial. So let us take a case. This was a 35-year-old male, had road traffic accident at 6 a.m. in the morning, went to GP at 8 a.m. with tingling in foot, referred to ortho at 10 a.m., had toe dorsiflexor weakness and intense pain, was given slab and a pain continued. Shifted to institute, narcotic analgesia was given, no relief. Seen at 1 p.m., tense compartment, absolute woody hard. That was very classical. Patient taken up for surgery immediately, and after decompression had a wonderful function. As soon as we give incision, you will find some muscles quite ischemic. So around 10 to 15 minutes is required to completely assess the muscles, whether they are live or have already gone necrotic. So these are the surgical steps in decompression. By single incision fasciotomy, give a long incision, raise flaps, go anteriorly. You will find patchy blood and the muscle which is ischemic, but the muscles bulge out immediately. We also have to release all the septa as well as the epimysium on the muscle. So this is adequate decompression. So as soon as you do this, it doesn't bleed much. All the muscles are decompressed, and it's a very good feel that the whole compartments are released. Whenever there is hematoma associated with proximal tibial fractures, we also have to decompress that hematoma. For decompressing posterior compartment, you need to take efforts. So along the fibula, you have to go posteriorly, release the fascia, and decompress the posterior compartment. If the deep compartment is quite affected, then we go on the medial side as well and release the compartment. Quite often, it is mostly anterior or lateral compartment. 20 minutes usually from the surgery, muscles seem very well to be vascularized, and in this case, we don't see any dusky muscle, which needs possibly more debridement. If you measure compartment pressure after the release, it usually drops down well below the 30 mm. At times, when you release compartment syndrome and the fracture is simple or a split tibial condylar fracture, we can achieve fixation in the same sitting with minimal implants. Previously, usually most of the times, X-Fix was the usual valuable tool, but nowadays, even with compartment release, if it is a complete release early in the setting, we can go ahead with the fixation and then manage with the VAC, etc. If a simple fracture is there and a good decompression is achieved, no dead tissue, VAC is a very valuable tool in managing compartment syndrome. See to it that we use minimal implant so that the risk of infection diminishes. Second look is usually taken after a few days, and a VAC is a valuable tool to reduce amount of secretions, soakage, etc., and secondary infection. A split graft provided early in the setting provides an early resolution of function. And a negative pressure wound therapy is a very valuable tool in managing compartment syndrome, even when associated with muscle necrosis. Splintage to provide equinus contracture is a useful tool because most of these patients, if not attended well, may land up with a equinus contracture that we have to prevent. And usually early compartment release leads to a good function and restoration of the muscle function. The prognosis is usually good if we do it within 6 to 12 hours, but it is not good if it is delayed beyond 25 to 30 hours, and probably is contraindicated after the third or fourth day, may lead to severe infections if you do compartment release at that time. And in these situations, when the patient present late, a foot drop brace for the first few months until fibrosis occurs is the main tool for management. And the final result usually is quite good, apart from the scar and the grafted skin. Compartment syndrome management, if done in time, is really rewarding, reassures the surgeon and the whole team, and avoids a catastrophic long-term sequelae. For tissue cover secondary procedures, a split graft or coapting sutures, but not like this. If you constrict the muscles over a dead tissue is not a good thing. Inadequate decompression again is not good. And if you want to do it, we can do lacing with VAC to reduce the amount of graft required. Very rarely we are able to close them secondarily if we have taken up a compartment release very early. Whenever it is associated with vascular insult, in these cases, when you repair the vessel or you remove a clot from a posterior popliteal artery, etc., a prophylactic fasciotomy is always mandatory in all compartment syndromes. When they present late and there is a vascular insult, it becomes a real problem. And in these cases, a lot of counseling is needed, a lot of follow-up is needed, and we need to assess the renal functions, etc. Friends, remember the complications of infection, ischemia, septicemia, and have sessions of counseling for these patients so that they are well informed. Remember, in vascular injury with compartment syndrome, time is crucial, and keep a high index of suspicion. If a vascular injury is there, the early recognition and management saves a lot of trouble. Friends, when the presentation of anterior compartment and lateral compartment is delayed beyond, say, 7 days, 5 days, and patient presents with foot drop, their compartment still is tight, and you need to manage and elevate a depressed fracture. In these cases, I would like to go ahead from a medial approach, not touching the lateral side at all, elevate and then fix minimally from a contralateral side screws and the medial fixation. Subtle compartment syndrome sequelae are not uncommon in clinical practice after tibial condylar fractures, and most of these patients present late with clawing of toes, etc. And when we do a fixation of the lateral column in tibial condylar fractures, I like to do a fasciotomy so that we avoid this sequelae. And this can be avoided in these patients. This is an interesting case shared by Dr. Jawahar Jetwa. This was after the angiography from the upper limb. Patient developed compartment syndrome. And this was the clinical presentation, and he released it in time, giving a complete restoration of function. In conclusion, I would like to say, if compartment syndrome is not treated in time, irreversible damage would occur within hours. We have to recognize the type and mode of injury. It can occur in leg, forearm, and other situations. Remember all the P's. Remember complications of reperfusion and muscle ischemia, and do a early decompression. Early wide decompression, including all muscle sheath, is the way to go for releasing compartment syndrome, and that lessens the morbidity. Thank you, friends. Thank you so much.
Excellent presentation, Chandak sir. There are one or two queries from my side.
Yes, sir. Please.
After releasing the compartment, the vac you used, what is the pressure you use for vac? Because already the compromised circulation, and when you use a vac by pressure, is there any chances of again re-ischemia because of the pressure of the vac? And second question, what is the pressure you keep? If at all, if you want to use the vac, what is the pressure you keep? And third question, is there any drugs they are present here in the arena of our treatment, medical line of treatment to increase the circulation after the patient?
Yes. Regarding question of using VAC, so whenever I use VAC for compartment syndrome after acute release, it is only when there is no vascular insult to the patient. The vascularity is all intact. So we release the anterior compartment and the lateral compartment by a long incision, ensure complete hemostasis, and use VAC at only 25 millimeters, and ensure that you are not circumferentially encompassing the whole leg. The VAC application is from the shin to the lateral side, so that the whole limb is not encircled in a tight ioband or tight adhesive film. These are the precautions I would use for VAC. So next day I would increase the pressure to around 75, use at a minimum pressure. So there are 3 gradients in the VAC machine. So use at minimum pressure so that there is no risk of hemorrhage. But if I find any clots coming out, rapid hemorrhage coming out, usually it doesn't happen, then I'll take appropriate care. This is how I would use VAC. VAC becomes a boon, especially when there are necrotic muscles, etc. Also, we have debrided completely. And then when we see the VAC in the subsequent setting, there is a lot of good granulation developing. So that is the advantage of using VAC. Coming to drugs which help us out, usually the routine line of management, apart from the appropriate antibiotic care, I would not be using drugs to reduce the compartment pressure. They, I feel, are not efficacious for reducing something like enzymes or steroids. I would not be using them.
Sangeet, you want to ask some question?
No, nothing. Thank you, Chandak sir. I think Dr. Agashe sir has joined. We welcome him.
Yes.
Thank you very much.
Yeah. Since you joined late, our frequency was also going down. Probably we have, now it has increased seeing you here on this platform.
Thank
So, can you take your
Sure.
presentation,
Sure.
sir?
Shall I share?
Yes, please. Till sir joins, Chandak sir,
Yes.
what is the extent of debridement? Like you said, only releasing the fascia. If you see a necrosed muscle, to what extent? To what extent you should take it out?
Yeah. So we debride all the necrotic looking muscle, flabby, not constricting, not on touching, on irritating the muscle, it's not contracting. Whatever has no vascularity is taken out. But in some situations, there are places where it is not exactly very clear whether this would survive or not. This muscle I would keep, and in the second debridement, I would have a second look debridement for this.
Exactly. That is what I was asking. What is the role of second debridement or second?
It is a great role, because everything would not be removed on day one. So whatever is live is definitely kept. Whatever is total dead definitely is taken away. And at times you can just take out the muscle by hand itself. When it is all necrotic, it comes out by hand peeling. It loses its elasticity, loses its constitution. So that we take out definitely.
Sir, usually what happens at that stage when you are removing those muscles, we are not aware of the anatomy because we never have such a large exposure. We never do a debridement to that extent where we are unaware of the anatomy of the neurovascular structure. So do you recommend anything, like keeping, like a pictorial diagram of the neurovascular structure handy, or, like how do you orient in that tense compartment, which is full of blood, full of necrosed muscle, you have taken larger incision, we never know where is the neurovascular bundle. So
Yeah.
how do you address that issue at that stage?
So basically, the usually the decompression is of lateral and the anterior compartment. If posterior is suspected, then it goes for the posterior compartment also. So all these structures are very well known where the anterior tibial artery crosses. So it is approximately 4 fingers just below that, and it is on the intraosseous membrane. So that we are quite aware of. Also, I would like many times to combine my plastic surgical team in the very first sitting itself, so that in the subsequent, whatever tissue reconfirmation is needed, he is also aware how for the first day look is. And as you suggest, keeping those diagrams mentally prepared is, I think, a fine value addition. Venugopal, you wanted to suggest something? Yeah.
Do you just take an incision over the fascia, or would you like to advise removal of part of strip of fascia?
So it is a wide decompression. At times, a strip of fascia can also be removed.
Yes.
So remove all tight bands. It goes on releasing. It's not only one look incision. Here it is a quite wide decompression, including all the muscle, septae, everything has to be removed. Whatever is tight, whatever is enclosing has to be undone. As the diagram suggested, we have to release it widely.
Chandak sir, when you are in doubt about the line of demarcation, about the dead live tissue, it is very sometimes difficult to judge whether this is a live or this is a line of demarcation. It is very difficult to wait.
Yes.
In a situation, say, if you wait for 1 or 2 days and have a second look, is there any problem of waiting for 1 or 2 days to line up demarcation to form?
I think second look is quite commonly required, and therefore in these situations, whenever the team is operating, it goes on taking consultation from each other, whether we remove this part, we don't remove this part, we keep it, then soaking it with warm saline, again observing after 10-15 minutes. It does require some rethinking, but whatever is definitely dead needs to be removed. Whatever is probably ischemic and may come over a period of time, which is in doubt, I think I would wait and have a second look debridement.
Chandak sir, it may be a very funny question, but like a simple question. How do you identify the two, if you have taken an anterolateral incision, how do you identify the two compartments? Actually, how do you identify, and what is the end stage of the release of this compartment?
Yeah, so the crux is take a long incision, raise flaps. Unless we raise flaps, so we are not able to see all the muscle bellies anteriorly and laterally, and the intramuscular septum also to be released. Then only the release is complete. And this is done by your previous experiences, by seeing over various diagrams, and those diagrams from AO are really wonderful. How do you release the compartments? So the compartment syndrome experience is gained over a period of time, and the whole team should develop experience into it, so that during difficult hours, there are colleagues to help you out in these situations.
So you said apart from releasing the fascia, the intermuscular septum, each muscle facial sheath has to be opened out.
Yes, it has
of
to
the
be
involved compartment.
Yes.
So
Yes,
that is a complete release of the compartment.
That is very important.
Yes. Agashe sir, can you share your screen?
There seems to be some problem. I'm not able to share the screen.
I think Mandar can share, and you can speak from your side, sir.
Yeah, I'll do that.
Yeah, Mandar, you can share your screen.
Okay.
Yeah, can you see this?
Yes, we can very well see.
Okay.
Hello, friends. At the outset, Dr. Chandak has already discussed about the compartment syndrome. I will basically discuss a few points, few pointers which will help us to remember important things about compartment syndrome. Next, please. So all of us know the definition and general management. General management is essentially fasciotomy. Next, please. So what more gyan can we give us? So a couple of proverbs in Hindi, Marathi and English, I have tried to correlate with compartment syndrome. So eyes don't see what brain doesn't know. Next, please. We must know the common conditions and locations causing compartment syndrome, but we must realize that it can occur anywhere in the body, whether it is leg, hand, it can occur in even paraspinal muscles. Next, please. There is a very nice saying, कोंबडं झाकलं तर आरवायत तरी आरवायचं थांबत नाही. Next, please. I have modified it a bit. Next, please. Next, please. Next, please. कोंबडं झाकलं तर कदाचित उशिरा आरवेल. That is very important. आणि आपल्याला उशिरा जाग येईल. कारण तुम्ही, if you give regional anesthesia, कोंबडं उशिरा आरवेल आणि आपल्याला उशिरा जाग येईल. So in case you are doing that, तर डोळ्यात तेल घालून लक्ष ठेवा. Next, please. A stitch in time saves 9. Even by delaying it by a few minutes or few hours, you can really have big problems. Next, please. And lastly, and most important, पुढच्या स्टेज मागचा शहाणा. There are several case reports in the literature about compartment syndrome which has ruined people's life, and we must take help from that and see to it that it doesn't happen in our hands. Next, please. So I'll go to a case. This unfortunate patient presented to us at 2 o'clock in the morning on 8th post-injury day. He had no movements of the wrist and fingers. He had no sensations below the elbow. The circulation was okay. I share some salient points about the history. Next, please. So this was a radius ulna fracture treated with close reduction under brachial block somewhere. Next, please. This is the history given by his father. Close reduction was done at night. Next day, the child was discharged. At discharge, he was not able to move his fingers. The RMO told the father that since regional anesthesia was used, this anesthesia as well as no movement is expected. Don't worry. Next. By 24 hours, he had significant swelling and blackening of the fingers, and there were no sensations. So these are the photos shared by his father. He was taken back to the nursing home. The fingers by then were totally numb. He had no movements. Next. So this is where we are. It's 24 hours. Patient is in cast, no sensations. So the surgeon called a senior orthopedic surgeon, rightly so. I mean, whenever you are facing this problem, you must involve your friend. The child was sent for urgent Doppler. We will discuss about it later. Next. And urgent fasciotomy was done at night about 30 hours after reduction. Next, please. This is the photo which the doctor shared with the surgeon. Then he was shifted to another hospital where the surgeon released the carpal tunnel also. Till then, only the forearm up to wrist was released. So the second surgeon released carpal tunnel also. Also gave 4 sittings of hyperbaric oxygen. This is on 7th day when he had planned for a skin graft, but the anesthetist said that, no, I'm not very happy with the wound, and therefore he advised debridement again. That was the time when patient shifted to our facility next. And this is how he presented to us. Significant slough, you can see. Tendons are totally necrotic. So I thought the first thing we should do is at least try and get a closed, uninfected fracture. The first step is converting this infected fracture into a closed, uninfected cavity. And then we will see what can be done. Next. So at this stage, when the debridement was good, I put VAC. Unless your debridement is good, there is no point in putting a VAC. The culture showed Acinetobacter, which was MDR, and therefore, and a gram-positive A viridans. So he was treated with polymyxin B, Targocid, and Metrogel. Next. So here you can see we have an excellent, next please, excellent granulation tissue. Unfortunately, the radius is exposed, which we excised and then put a split thickness graft. The graft take was good. Unfortunately, he developed significant volar angulation, as you can see. And then again, the radius started poking out. So this had to be corrected. So we again excised the radius, corrected the angulation. Next. And I nailed only ulna, did not nail radius because the radius was a bit of exposed in the wound. Next. So at 2 months, 10 days, next. Wounds have healed. I have corrected the ulna. Next. Wrist was in significant volar flexion. There were no movements. Next. No sensation on the volar aspect. But one important thing that had happened was he had decent touch and pain sensation on the dorsal aspect of forearm up to middle third of forearm. So then, because of the volar flexion, Dr. Warrior came in, he manipulated the wrist and gave a plaster cast. This is him holding Dr. Warrior's hand, and you can see the fractures have united quite well. Next. By 11 weeks, he had started getting some movements. You can click, Mandar. Sorry. He had some movements of the wrist. Just a flicker. Just a flicker. Now, next. So this is at 6 months. Again, he has flexion contracture of the fingers. Only thing is, we have converted this into a closed, uninfected fracture for sure, with appropriate angulation. So this is a time for reconstruction now. Next. So Dr. Kumtha, Purohit and Sudhir Warrior took over from there, and they did a micro sural flap as well as lateral thigh flap. Next. This is him after the flap take. Next. To which they put in gracilis, did a gracilis transfer, and the video is not running. Anyway, he does have finger movements now. So friends, we may make or break somebody else's life. So Purcha states Maksa Shahana. Next. So let us revisit some important points of this case. Next. So A, synthetic cast at the time of close reduction of fracture. B, possibly flexion was given later, invaginating the plaster and decreasing the venous return. Next. The close reduction was done under regional block. Next. No movements or sensations were attributed to regional block. Next. And Doppler done. So all these things played a very, very important role. Next, please. In development of acute compartment syndrome, which is next, which is nothing but a life-threatening or limb-threatening condition observed when perfusion pressure falls below tissue pressures in a closed anatomic space. Next. This results in nerve or tissue damage. So either the pressure is too high, the pressure is essentially too high, either because of increased fluid content or decreased compartment size. There's several causes to it. Next. So in coming back to this case, here you can see there is a invagination of the plaster at the elbow, that possibly because flexion was given after the plaster was given, and that possibly decreased the venous return. So what are the common causes of compartment syndrome? This was a big paper of almost 164 patients over 8 years. 38 of them were non-fracture causes. These are the trauma causes. Males far dominate females, 13-1. Tibia shaft and upper end tibia is more common. Ipsilateral distal radius and elbow injury is more common to produce compartment syndrome. Almost 15% patients of this such injury or floating elbow can lead to compartment syndrome. Remember, open fractures are not exempt and compartment syndrome because the muscle are good, but the facial compartment doesn't, the fascia sheath does not increase the size. The size of facial sheath does not increase. Next. As opposed to patients who had no fracture, developed compartment syndrome because of non-traumatic causes. The percentage of females is a bit more. That means 3:1 as compared to 13:1. These patients have more comorbidities. Deep-seated infections can lead to this. Remember, some drugs are attributed to this: anticoagulants and statins. Statins cause myositis and cause muscle thickness. And posterior compartment syndrome is more common with non-traumatic group. Next, please. Now, progression, once it develops, the progression is very rapid. You can see patient presented 1 hour post-injury with compartment syndrome, and within 6 hours, the swelling was phenomenal. Next, please. So untreated, we all know that it can lead to a Folkman's ischemic contracture. Next. Now, how do you diagnose? I'm sure Dr. Chandak has discussed this. So essentially 6 P's: pain, pressure, paresthesia, and we must make a diagnosis at this stage and release at this stage when patient has pain out of proportion, muscle is tense, and there is paresthesia. Movement, paralysis, and pallor and pulselessness develops, then we have missed the bus. By then, it is too late. Next. Several pressure management systems are in use. Hardly any centers in our country have this. Next. So remember, if you have this, this has to be, the pressure has to be measured within 5 centimeters on either side of the fracture. Next. And only the pressure is not considered important. It is the delta P, that is diastolic pressure minus tissue pressure, is considered to be important. Next. Now, often in our country, people say that we don't have facility for pressure management, and therefore we miss. And coming back to a few studies, now these are 2 papers back to back I am quoting. This was a prospective study of almost 100 patients of tibial fractures, and they did monitoring regularly. Now, next, please. What they realized was, if they had used the threshold of delta P, then almost half the patients would have undergone fasciotomies, leading to unnecessarily operations. Next. So what is important is clinical suspicion. The gold standard is clinical suspicion. Then one may use pressures for confirming the diagnosis. Similarly, here, 8 out of 19 had these elevated pressures. So don't think that since we do not have pressure management, we can afford to miss compartment syndrome. No, it is the clinical. That should lead you to the diagnosis of compartment syndrome. Next, please. And these pressure measurements are essentially reserved for diagnosing chronic compartment syndrome. Next. So here, as you see, the compartment syndrome was diagnosed almost a day after this. Now, what is the next, please? What is the role of fasciotomy? And what is the role of early debridement, early fasciotomy? So here you can see, moment a fasciotomy is done, the muscle starts breathing, the vessels open out. Next. Next. And therefore, must do a fasciotomy within 6 hours, ideally, because nerve damage occurs much earlier. Next. So what is the role of regional anesthesia? In this case, there was no pain and no movements and sensations. Next. So there are several reports in the literature of compartment syndromes at various levels because of regional anesthesia. Here, a knee arthroplasty was done and patients had developed gluteal compartment syndrome. Next. There was a review of literature of 28 patients with gluteal compartment syndrome under epidural under knee arthroplasty. Half of them were overweight, and the worst thing was almost 1/4 had developed compartment syndrome on the downside or other opposite side of total hip replacement. Next. Again, this is a story of compartment syndrome which was missed because of, next please, nerve blocks. Next. So first post-op day, he had no pain, 0/10 on VAS score, while second day, he developed very severe pain despite nerve blocks and oral opioids. Next. Fasciotomy was done on second day, but next, significant tissue loss resulted. So regional blocks, some tips for us is the surgeon himself should give plaster. Confirm that the dressing or plaster is not too tight. Never flex the elbow after giving POP. Next. And possibly a good system to follow would be make a video call. You may not be able to go to every patient of where you have done reduction, but at least make a video call, confirm that he is moving the fingers, confirm that the plaster is not tight, and then only patient is to be discharged. Next, please. So, role of angiography and Doppler, unless you are suspecting vascular damage, don't waste time in doing a Doppler. Next, please. So what does happen if fasciotomy is delayed? Here you can see the mortality, even in 6 to 8 hours, can be as high as 5% and 15% amputation rate, because the muscle mass or muscle necrosis is quite common. But if it is delayed, then mortality can be as high as 19% with amputation rate of almost 1/3. Next, please. Same thing. Next. Next. So surgical consideration, Dr. Chandak has already discussed. I'll just emphasize one thing. It is not only fasciotomy, necrectomy or excision of necrotic muscle is very, very important. Next, please. So this will be discussed at length. Next. Next. These are the various compartments. Next. So finally, eyes don't see what brain doesn't know. So you must keep reading about compartment syndrome and you must be on your toes whenever you are dealing, next please, dealing with some troublesome fractures like mid-shaft tibia or upper end tibia. Next please. Various measurements have been described, the widest part of femur versus widest part of tibia. Next. And the displacement of the axis of tibia from femur. Next. 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 But one should not be complacent. I'll just give an example. These are two of my cases. This really was a classic case for compartment syndrome. And he actually, next please. He came at 12 hours with a huge swelling and compartment syndrome. But next please. But compare it to this. Really straightforward looking X-ray. Next. Next. All the measurements normal, but had a huge swelling and compartment syndrome. Next, please. Finally, remember, medico-legal aspects are very, very important. Can you just run through these slides now? So next, please. Most of the cases of compartment syndrome, patients really suffer, and if sued, doctor has to, most often, more often than not, it goes in the favor of patient. Next, please. I'll just run through this. We can just go to the last slide. We must remember Folkman's contracture is different than compartment syndrome. Next, next please. Chronic compartment syndrome is essentially, next please, is related to repeated activities against a tight compartment. So to recapitulate, friends, 3 out of 5 senses play a major role in management of compartment syndrome. Next, please. And we have a very narrow window between diagnosis and treatment of compartment syndrome. Very narrow. You have to do an urgent job. Next, please. So take home would be next. Eyes don't see what brain doesn't know. You can just run through, Mandar. Beware of regional anesthesia. Must do an urgent job. And next, please. And remember to learn from somebody else's mistakes than your own mistakes. Thank you, friends.
As usual, wonderful presentation. But I have one query from to answer from you.
Yes, please.
There are blisters are there, but still functionally the patient is able to do all movements. There is only a pain in the finger. And there are blebs in such a situation. Do you advise fasciotomy or you just observe?
See, whether they are blebs or no blebs, if your clinical diagnosis is pain out of proportion to the injury, significant swelling and significant pressure, the muscle feels tight, then whatever may be the skin condition, you need to explore, because the pressure inside will go on increasing and the soft tissue injury or soft tissue problems will go on increasing further. So you'll miss the bus if you don't explore only because there are blisters.
Sir, to continue it further, now the blebs or the tense compartment, what you see, or the redness or the edema, what you see after a tibial condyle or a pylon fracture, all of them are not compartment syndrome. Correct me if I'm wrong.
Yes. I mean, not every blister means compartment syndrome.
Right. Right.
But blisters can occur with compartment syndrome.
Yes. So if you see post-operatively, like in those high velocity injuries of tibial condyle or pylon or of the elbow, the blisters, that doesn't mean they are going, all of them are going to develop a compartment syndrome or all of them would require fasciotomy. So as you suggest, it is a pain, clinical suspicion, which will conclude that. Now, in the case which you have shown of the tibial condyle, now he had both the soft tissues were tense, he has developed blisters, and at the same time he developed compartment syndrome. So how do you identify those common situations? Because either you put them in a plaster or a fixator and you leave them alone. Can they also subsequently develop, in spite of immobilization, these tibial condyles or the pilon? In spite of immobilization, can they further develop compartment syndrome? And you have to be watchful for that.
Correct. Those two cases which I have shown presented with extremely tense swelling, extremely tense, and we did fasciotomy immediately. Now, as regards the first case was concerned, he presented late. Though came in with compartment, he had done massage and all, the soft tissues were very poor, and the diagnosis was made moment I saw him. There could be a condition where compartment syndrome is possibly developing, and that is the most troublesome thing. It generally what I do is, I feel that this patient does have tense calf, but it is not that tense that I have to explore him immediately. So one has to be, as I said, doyat tel ghalun laksha theva. Number one, I will avoid giving any opioid analgesia. I will definitely not give what is called PCA or patient controlled anesthesia. I will like to give him, I of course give him analgesics, but not dope him. Number two is I'll be watchful about a few things. Now, all these 4 compartments have one nerve with them. Paresthesia along that nerve will indicate that the pressure is increasing significantly and I have to explore. So any paresthesia, especially at the web space or on the heel, posterior aspect of heel, will indicate significant pressure in the compartment. So then I will definitely release. These are some markers where I will observe them, but after say 2 hours they develop this, I will release. The constant examination is important. The most common, of course, is anterolateral compartment of the thigh, which becomes very, very tense and easily palpable. That is the time, if you feel that the tenseness is increasing, I would definitely release that.
So many a times after the hip surgery or after a femur surgery, knee surgery or tibial surgery, or even after total knee replacement, many of our patients get a very swollen, tense leg. So are all of them impending, where DVT has been ruled out, all of them, do they fall in that early compartment syndrome?
See, still there are some gray areas. You need to keep them examining again and again and check their analgesia requirement, painkillers ka requirement. If that goes up, then that is a sure shot indication that you have developed a compartment syndrome. If that starts going down, then it is likely that they are going to settle on their own.
And the question, maybe you can answer, Chandak sir, as well. Those compartments which have improved and you have not done fasciotomy, what is the, how do they behave? And on which day their symptoms start disappearing, or how much time they require to recover?
Yeah. Dr. Chandak, will you like to answer first?
Unmute yourself, sir. Sir, unmute yourself.
Regarding your last question, how do you identify those post-operative patients and tense compartment with blister? The classical presentation is sister would be coming to you, sir, punha injection magtat ate. 2 dile, 3 dile, paracetamol dile, Voveran dile, tari पण pain hoto. So they would come out with more increase, as sir said, lot of painkiller requirement, and they are writhing in pain. They are not comfortable. If we go and counsel them that post-operative pain would be there, but they are still very restless, pain, and this stretch pain during this period identifies this patient. So anything they would be asked to do movement, they won't be able to do complete movement. And when you do by passively, that stretch pain in the post-operative phase is one thing which is clinching. Regarding the question you asked, whether compartment syndrome and you have not treated, how do they behave?
No. They have not, it has not established completely. And you have conserved that patient. It is not a late presentation. You are aware it is a compartment syndrome, but that did not require a fasciotomy. It didn't worsen.
So these are the patients, I think, which I would always repent later on. And I remember my around 10 to 15 patients where I should have done compartment release. I did not do it. And in all future courses in the follow-up, if you find subtle compartment syndrome missed is not uncommon. And in one of the series, they reported as large as 5 patients in 100 after tibial nailing fractures where they would develop clawing of the toes. Those are actually minimalistic compartment syndrome of the anterior or the lateral compartment going for clawing in the follow-up. So we would miss some of these compartment syndromes. Definitely in the follow-up, clawing develops.
Flying of the toes as well as TA contracture. TA contracture also is one of the finding.
One very important thing I would suggest again and again is dressings. Very often we feel that we have given good dressing, decent dressing, it becomes very tight. And we must release that. The first thing when a patient starts complaining of very severe pain, asking analgesics again and again, is to get down to the skin cut the dressing, get down to the skin and open the dressing. That is the first thing one has to do.
Yeah, my observation, this is very common with the distal radius fractures. We don't keep the drains, and they have a they have a blood loss or soakage from the wound post-operatively.
Correct.
And you have given a slab. Very often on second day, they starts getting that CPRS type of picture, edema, they cannot flex, they start developing pain. And it is all the contracted or dried up gauze piece or hematoma, which is adhered to the wound, and that is constricting over the slab. So always, that is a point which Agashe sir said.
Yeah,
we remember.
The blood cake.
Yeah.
Blood cake, yes, blood cake.
Agashe sir, there is one question from Dr. Samrat. He wants to know if the patient comes late, he is not touched, closed fracture, comes on third day, fourth day, or fifth day, already an established compartment syndrome. So how do you go along for those patients?
This is a classic catch-22 situation. You ideally, according to the literature, you should not touch them because chances of infection are very, very high. So let them develop Folkman systemic contracture and then treat accordingly. Now, why I said catch-22 is you don't know exactly when the compartment syndrome has developed, whether it is day 1, whether it is day 2 or day 3. So from that point of view, one has to be sort of treat every case on its own merits. But essentially, if you treat them late, you do a fasciotomy late, there is very, very high chance of getting infection and going into having more trouble. So it is safest not to touch. Safest, allow them to develop Folkmans and then treat accordingly.
Sir, these blebs which you spoke about, we get after these fractures like tibial condyle or pilon. Now, how are these different from the one which we get in compartment syndrome? One question. Second is, many a times we take an incision and post-operatively when we check the wound, there also you get the blebs. Now, these are three different situations. So
generally black blebs, dark blebs need to be differentiated from clear blebs.
Hemorrhagic against a non-hemorrhagic.
And I think, Sangeet, you are the best person to explain because you have presented a paper on that. So if you can explain.
Yeah. See, basically those blebs represents the skin injury. And here compartment, they will always be non-hemorrhagic because it is because of the loss of blood supply of the skin following increased compartment pressure. So they do not develop early, they develop late. And why do we get it after the incision? That is because of poor soft tissue handling, nothing else. You damage the skin and that is why they get those blebs. The same is the situation with the tibial condyle or pilon fracture. That represents the high velocity injury and the damage to the skin, which gives rise to bleb within 6 to 8 hours.
Sangeet sir, wrist and ankle, they are particularly very uncommon for the compartment syndrome because they are not having the compartment. And also during the wrist plating and during the anterolateral or the anteromedial approaches to the pilon, you release all the fascias to plate the bone. So how common it is to get a post-operative compartment in wrist and the ankle when they have no compartments and you have already released the fascia. So I think majority of the time it should be the soft tissue handling could be the cause rather than the compartment.
Yes, exactly.
And bandage.
Bandage, yes.
Tight bandage.
Sangeet, what you said about the clear fluid in the compartment. So I'll share this just one photograph which signifies your point. So this is the photograph. Able to see this?
Yeah.
Yes.
Yes. So this was the case shared by Dr. Jawahar Jetfa sir after a upper limb angiography, and this was immediately within few hours. So you can see it is all clear. As you said, it is
Non-hemorrhagic.
non-hemorrhagic. So very good point I noted, Sangeet.
Yeah.
Thank you.
Sir, Agashe sir, you mentioned that open tibial fractures can also develop compartment syndrome. Now, like the situation where tibia and fibula have fractured. Along with that, the intermuscular septum are disrupted. So already there is a fasciotomy inside. So how can they develop a compartment syndrome?
Couple of things. One is that fasciotomy is very often very small.
Incomplete.
Incomplete. Extremely incomplete. It is essentially a small piece of bone which has torn through the fascia and has come out. So it is an incomplete fasciotomy, but a significant muscle damage or significant muscle injury, which would lead to compartment syndrome. Occasionally, you can have a crush syndrome where the leg is entrapped and the muscle gets crushed completely. There is an open wound. So you will get crush first. You may get myoglobinuria first. You may have renal problems first, and you'll have compartment syndrome later. So these are the two situations where you can have an open fracture and a compartment syndrome.
Second question was individual compartment release. How do you decide? Now, the commonest, as Chandak sir said, is the anterior and lateral compartment. Now, how do you decide whether that patient requires the posterior compartment release also, or he does not? So,
that is, sorry.
Yeah.
That is entirely clinical. First release the anterior lateral, which is commonest. After that, feel very often that posterior compartment doesn't feel that tight then. And then there is no harm in waiting.
So,
but if it remains tense, then I would go ahead and release. And I would, sorry.
That means it may be early, like if you have, the patient has come to you at 6 hours. He may be in that stage where only these two compartments are involved at present.
Correct.
The posterior is going to develop later on. But you have intervened, you've done the surgery within that 6 hours.
Correct.
So now, how do you handle that situation?
Generally, it doesn't happen because it's like this. If you're opening one compartment, your threshold for opening the other compartment is very low. That means on table, if you are doubtful, you will still go ahead and open. You will not open only when you are dead sure, absolutely sure that this is soft, I'm not going to do it. And that generally happens in non-traumatic wounds. Generally, there's an abscess and you have only anterior lateral compartment involved, only posterior compartment involved. That is common. But in a traumatic situation, generally all four get involved. And as I said, if I'm in doubt, I'll release.
Venugopal, you have to say something.
Sir, is it not better to do a complete job rather than to feel that I'm secured, I have not done this?
No, I totally agree with you. Only thing is sometimes you are dead sure, especially in a non-traumatic situation. Like you have an abscess in the anterior lateral compartment. Then there is no point in draining the posterior compartment. You drain only the abscess or a hematoma leading to compartment syndrome.
And the last question now before we move to the next is, when should you have a second look? Or something related, should we do a plastic closure procedure at the same time, like a split thickness? Or when should we do it? These two questions. When should we have a second look, 48 hours or later? And when should we do a cover procedure if everything is red? There is no more necrosed muscle seen.
See, this 6 hours business hardly ever works in our country. Most of the patients come late. Most of the times you have to do nephrectomy. And therefore, it is best not to close this on day one. 100%. Cover it on day one. is what I think. I would definitely explore at 48 hours. That is the time when I might think of a split thickness or a WAC or that shoestring lace. You know, what is it called?
Shoelace sutures.
Shoelace sutures. So that is what I would do at 48 hours. If I feel that there is no more muscle necrosis, I will not cover till I'm sure that there is no muscle necrosis. Even if I'm in doubt, I'll not cover it. And you may find newer and newer areas of dead muscles once you know, at this time of second look.
Parag, Girish, Mandar, any opinion on that? Same, all of us agree with that.
Yeah.
Okay.
I only would like to suggest here, sir, apart from surgeon, we should involve in a senior citizen is a nephrologist from day one.
Yes.
And we have to monitor electrolytes and creatinine of these patients very frequently. Usually, these patients require forced alkaline diuresis. We have to give a lot of fluid because rhabdomyolysis can be prevented. I mean, if it enters into systemic circulation, the only way to save kidneys is post-alkaline diuresis. And as a surgeon, we may not interfere with the IV fluid management as our knowledge, is limited there. I would recommend to involve a nephrologist, at least in a diabetic and more than 45, 50-year-old patients in lower limb trauma with compartment syndrome.
You're absolutely right. I totally agree with you. It's a multi-speciality treatment. It is not only our job. Perfect.
So, Chandak sir, how do we know whether there are questions now from the delegates? You are checking that?
So I'm following only my WhatsApp where I am not finding any. So if you can put one slide and give our WhatsApp number, I think that would be fine. So all the delegates, we request you, one of us would be known and our numbers would be there. You can put questions to our WhatsApp. I think that is the quickest way. However, I'll also find out the link from the YouTube and get back to you.
Yeah. Okay. Okay. So can we move to Mandar now for his talk on compartment syndrome in common pediatric situations?
Am I audible and screen is seen?
Yes, very well.
Yes.
Mandar, first of all, I thank you for synchronizing with sir.
Thank you, sir.
I understand you must be in a lot of pressure, tremendous pressure, getting it right, synchronizing it so well.
Thank you, Mandar.
It may be first time.
Thank you.
But the sequence of change was absolutely perfect.
The slides were automatically changed without sir asking.
Thank you very much.
Yeah.
Thank you.
Thank you, Mandar, for that.
All right. So should I start, sir?
Yes.
Yes. Thank you very much to Maharashtra Orthopaedic Association, Dr. Gadegone sir and Dr. Gawhale sir for involving me in this session. So this is really an honor for me to be involved in the Veteran Surgeon Forum. And when I was trying to prepare this thought, what I thought was, what will I be talking about? There are absolute diggaj here who will be talking to us about so many different things. So I thought that I'll tell what I will not be talking about. I'll not be talking about definition of compartment syndrome. I'll not be talking about how to diagnose routinely about compartment syndrome or how to do a compartment release. But what I will try to do in the next 10-15 minutes is we should know that compartment syndrome in children is an evil like Ravana. And just like Ravana had 10 evils, I'm going to talk about 10 characteristics of compartment syndrome in children. 10 characteristics or 10 different scenarios of compartment syndrome in children. So let's go to the first. First is the diagnostic signs. In the last couple of lectures, we know that the diagnostic signs for compartment syndrome are 5 Ps: pain, pulselessness, pallor, paresthesia, paresthesia. But is this really true? Is it there only in adults? Well, in children, the scenario is different. The diagnostic signs in children are these 3 A's, which are anxiety, apprehension or agitation. Just like Chandak sir said, the patient is absolutely agitated, and this is very, very commonly seen in children, and increased analgesic requirement. Now, it has been shown in a very good study that increased analgesic requirement picks up compartment syndrome almost 7 hours prior to other 4 P's other than the pain. So you should always look at increased analgesic requirement. So I always tell my anesthetist who's always worried about a post-op pain ke liye kya hoga. So I always tell them, if my patient of a fracture fixation requires anything other than a simple ibuprofen or a paracetamol orally, then I'm in trouble. I'm going to look at that patient again. So increased analgesic requirement is something which is extremely important in children. Next common scenario is compartment syndrome in a type 3 supracondylar. Now, I'm sure with all our faculty members and the delegates, many of you must have treated kids like this. You have a displaced fracture supracondylar humerus with a displaced lower end radius or something like a floating elbow. The child usually has severe swelling with a deep pucker. Distal pulsations may or may not be present, but the hand is warm and pink. And you have a scenario like this, a huge amount of swelling. There may be a small puncture wound. And just before the OT, the pulse is not palpable. So this is a typical scenario with a posterolateral displacement with an anteromedial spike with a neurology intact, but radial nerve not palpable. And this is a pink pulseless supracondylar. Now, I'm sure every one of you must have treated a lot of pink pulseless supracondylars. And what happens in a pink pulseless supracondylar is that the proximal fragment impales inside the brachialis and starts compressing on the neurovascular bundle anteriorly. And the neurovascular bundle is intact, but it goes into severe amount of spasm. So the treatment for that is fixation. So we all know, we have learned with so many lectures about pink pulseless supracondylar. You fix it absolutely accurately. But the same patient, sister calls up, sir, wo ekdam psycho or relative ekdam ye hai, bahut sara kuch diya, diclofenac suppository diya, fir bhi ro raha hai. And severe pain on passive movements. And on opening the cast, he has severe swelling. Now, this is compartment syndrome after a pink pulseless supracondylar. And this occurs because of the reperfusion injury and revascularization, which happens after we have relieved the spasm of the arteries. So always be mindful of being very happy after we have done a very good job of fixation. The job has not ended. The job will end probably after about 24 hours after the child goes home and sees to it that there is no compartment syndrome post-operatively. So it's in supracondylar humerus, it is seen in about 0.2% in all supracondylars, about 0.8% in type 3 supracondylars. Very importantly, it's seen in almost 25% of all type 3s with a forearm fracture or a lower end radius fracture or a floating elbow, and in about 10 to 15% in pink pulseless supracondylar. So whenever we have a floating elbow or a pink pulseless supracondylar, always be wary of a compartment syndrome, especially post-op. The second common scenario is something which looks very benign. This is a real life scenario. This was a very, very benign looking X-ray, a grade 2 supracondylar. As you can see, the anterior humeral line is passing anterior to the capitulum. And this was sent to me by a very senior orthopedic surgeon. Arey, kya must reduce ho gaya, dekh aisa strap laga diya main, hyperflexion mein. But what is important to know is look at the entire X-ray. And what you can see is this huge amount of swelling anterior. So don't just look at the X-ray here. Look at the swelling anteriorly, and that is something which always needs to be, you have to be very careful about it. So if you want to read one article about compartment syndrome, this is one article by Scott Mubarak in 1979. I was fortunate to be doing a fellowship under him in 2012. So he has described the causes of Folkmans, and he said that many of the patients, the common cause of it is flexion of the elbow in more than 90 degrees of flexion, especially in a type 2 supracondylar. So in a type 2 supracondylar, if you have an anterior shadow, which is significant, if you have an anterior swelling, which is significant, and if you are having difficulty in flexing the elbow beyond 90 degrees, don't do it. It is preferable to fix the fracture rather than hyperflex the elbow. So be very careful of type 2 supracondylars equally as much as a type 3 supracondylar. Next, we come to distally forearm fractures. Another very excellent article by Chris Sauder et al. He says, surprisingly, forearm fractures are commoner causes of compartment syndrome than in supracondylars, though it is more in combination with a supracondylar humerus fracture. And the common cause is multiple reduction attempts, especially when you are doing a forearm nailing. So many times you are obsessed with getting a close reduction. Close mein hi aana chahiye. And you manipulate the fracture so many times. Then eventually when you open, it leads to something like this, which is a tense compartment. and that can lead to a compartment syndrome. What's so unique about femur fractures in children? Well, femur fractures, again, a very good article by Scott Mubarak described something known as a 90-90 cast. Well, in fractures of the femur, many a times the position is 90 degrees of hip flexion and 90 degrees of knee flexion. And initially, the way they used to apply this spica used to be a spica over the abdomen, a spica over the legs, and then you reduce it by pulling it on it and then put the femoral part. Now, what used to happen is that this part used to slide back and cause compression at the proximal tibia. And that used to be extremely dangerous, and that used to cause compartment syndrome of the leg compartment. Another common thing which in femur fractures which can cause compartment is the oft-repeated gallows traction. I'm sure many of the seniors are very well versed with gallows traction, especially in young kids. But what happens is, as seen in this child, the knee goes into hyperextension, which leads to vascular compression and compartment syndrome of the tibial compartment. What about tibia fractures? Where again, everything has been described. We know that midshaft tibias or tibias, just like this, where even if there is a puncture compound wound, it's a small fasciotomy which has been done for a big compartment syndrome, and that leads to compartment. But that is not what is unique in kids. What is unique in kids is a fracture which looks very benign, is this, which is tibial tuberosity fractures. This is something which is very dangerous, because what is important is that there is this anterior tibial recurrent artery which is right there, and usually that gets avulsed, and that can be a cause of compartment syndrome. So it is common in adolescents, especially after a high velocity sports injury, something like football or kicking the ball, and almost 20% chance of compartment syndrome in this very benign looking injury. And some authors have even advised a prophylactic compartment release when you're fixing these fractures. Something about neonates, where there's this birth trauma injury which can cause compartment syndrome, something like this. I'm sure if you can jog your memory, in Gynac we used to learn about various presentations, and this is something which is known as compound hand presentation. Now, this compound hand presentation is when the hand gets presented in the cervix, but the hand gets pressed between the head of the child and the mother's pelvis. And this is an emergent situation, but there is a constriction of the upper limb just at the point above the elbow. Now, this is one of my patients in the NICU. You can see that there is severe swelling in the arm just below the elbow. There's severe swelling in the dorsum of the wrist. And what is important to know is something which is very unique. There's this band, which is the reddish band, which is known as a sentinel sign, which is the place where compartment syndrome has started. And this is a well-established sign, especially in this article by Ragland et al., who described 24 cases of forearm compartment syndrome in neonates managed by fasciotomy. And they said that unless you do a fasciotomy within 24 hours, the result is very poor. I had to take this child up for compartment, but unfortunately, the child succumbed due to some other cause. We also published this article in JBJS American about lower limb ischemia following spontaneous arterial thrombosis. Now, this child had a compartment, and eventually this led to a gangrene, and we had to do an above knee amputation. Another common scenario is compartment syndrome in NICU. In NICU, the common scenario is low birth weight or extremely low birth weight kids who had prolonged IV requirements. The poor neonatologists have to change IVs every couple of days. And what happens is they have multiple comorbidities, and there is a very high chance of IV extravasation. Now, compartment syndrome following IV extravasation is very unique because it involves both the deep as well as the subcutaneous tissue. So this is one patient of mine. You can see that there is a lot of skin necrosis, but with severe deep swelling on both the dorsal as well as the volar side. I had to do a dorsal as well as volar compartment release, and you can see that there is a huge amount of skin necrosis which happens post-operatively, which is not seen in any other case, and you have to do a lot of plastic work after that. One of the last is post-infective compartment syndrome, as has been discussed previously. Deep osteoarticular infections are very common in pediatrics, and especially in the forearm, they can lead to a selective compartment syndrome. So you have this child who had a very tense volar compartment, who had already had this short length phenomenon or the Folkman sign, where the child was able to extend his fingers in wrist flexion, but was unable to do that in wrist extension. And on opening, we could see that there was a huge amount of collection because of a deep radial osteomyelitis, which required multiple other procedures. Last but not the least, compartment syndrome due to medical or hematological causes are extremely common in kids who have leukemias or DICs or other hematological conditions. This diagnosis is extremely difficult because the child is usually having multiple comorbidities, ICU stay. And so beware of a child who presents like this. You have a child limb looking normal, but this limb having extreme swelling and who has a hematological condition which presents with severe pain in the limbs, always be aware. Thus, to reiterate the 10 evils of compartment syndrome in kids, remember about the 3 A's of anxiety, agitation, and increased analgesic requirements. In supracondylar type 3s, be careful about especially in the ping pulseless and the floating elbows. In type 2s, they are not as benign as they look. Look at the anterior shadow. In femur fractures, especially when you're doing a 90-90 traction or a Bryant's traction, look at the distal circulation, look at the swelling of the tibial component. Forearm fractures, never take more than 2 or 3 attempts when you're doing a reduction. Do a mini open, that is much better than struggling with a closed reduction. In tibial tuberosity fractures in adolescents, look at the swelling, know about the anterior tibial recurrent artery which can get avulsed. Neonate compound presentation can have this compartment syndrome, especially when you have the sentinel sign. NICU extravasation is extremely difficult. It involves the superficial as well as the deep compartment. Post-infective and post-hematological conditions are very important. Be aware of that. Thank you very much.
Mandar, very wonderful presentation.
Thank you, sir.
And we have given a very detailed explanation of each and every condition. And this is a 10 Ravana heads. That is one of the wonderful concept of presenting a compartment syndrome in such a webinar.
Mandar, excellent. Now, there is a particular situation where, like a supracondylar fracture or a distal radius or a tibia, where you had promised the patient's relative that it is a closed procedure. It requires only percutaneous implants. And after 24 hours, you have to explain them that the complete forearm has to be opened now. And you don't know what is going to happen. What will be the result? How do you handle that situation?
I know it's a very difficult situation.
Because every surgeon will try to avoid that. Either, or for example, you have given an X amount of budget. Now it is that has crossed already. And everything is going to go haywire. One is a budget. Second is, it is difficult for an individual surgeon to explain. This is a complication which is not related to him or his surgery, but it is something which has developed unfortunately.
So, sir, one of the things which over the years I have started doing is always present a grim picture when I am treating it de novo. So, especially when it's a supracondylar humerus fracture, I always say कि नहीं सूजन बहुत ज़्यादा है, इसके लिए जल्दी करना पड़ेगा. सूजन कम नहीं हुआ तो कुछ issue हो सकता है. So the relatives have already known that there is some issue of swelling, some issue of some complications which are possible even after the surgery. So I always try to have a very grim picture when I'm dealing with these sort of fractures, a type 3 supracondylar or a floating elbow or a tibial tuberosity fracture or a high energy tibial fracture. So that is one thing. Secondly, what I suggest is that we should always, when we are trying to explain a complication, always have a couple of other colleagues with us, the plastic surgeon or the pediatrician or the intensivist with us, and so that I think when unity lies in number, it's always better to explain as a collective front to the relatives.
Yes, Venugopal.
Mandar, I wanted one tip. You said do not flex the elbow in elbow injuries in pediatric patient, but in Monteggia fracture dislocation, we usually need to flex it above 90 to keep the head stabilized, radial head. So what tip would you give in that situation?
So surprisingly, the Monteggia fractures are extremely unlikely to have compartments. The velocity of injury and the amount of trauma is much lesser in a compartment in a Monteggia. So in that case, it is it's relatively quite safe as compared to a supracondylar humerus fracture. So I know that the reduction maneuver itself is hyperflexion, but even then I think it is quite safe in the Monteggia fracture.
Mandar, in one situation, suppose there is a pulseless, there is no radial pulse is not palpable, but there are finger movements are good and you have reduced the fracture.
Right, sir.
Reduction is also near about perfectly done and you have applied a cast. In that case, would you like to do a fasciotomy or just observe that?
So if you are dealing with a pink pulseless supracondylar, so that which means that the capillary refill is good and I am having a good waveform on pulse oximetry. It is something, and then I have got a good reduction. So now the importance lies with attaining a good reduction without an anterior gap. What happens is that sometimes you get a very soft reduction and there is an anterior gap, which means that you have a chance that the neurovascular is impaled in the fracture site. That is the time when you have to be very, very careful and probably monitor it significantly. The second thing is I almost never give a cast in a supracondylar humerus fracture post-op. I almost always put the child only on a slab. That too, it is never in hyperflexion. It is almost slightly less than 90 degrees of flexion. I do not wait for return of pulse after fixation of a type 3 supracondylar with a pink pulselessness. It has been shown by many papers, especially by a paper from Ganga Hospital, that the return of pulse can take almost 6 weeks. So I'm not worried about return of pulse at all. I am only looking at a good brisk capillary refill of less than 3 seconds and a good waveform which is bounding and which is rhythmic. So that is what I am always looking at.
Sangeet, I think there are 2 questions on the chat box.
Yes, sir.
One is from Dr. Sanjay. He says compartment syndrome in head injury patients as a clinical diagnosis may take more time and may be delayed. So what is your take? Question to Agashe, sir. And the second question is from Dr. Nitin Patil. Experience about fibulectomy for decompressing all the 4 compartments.
Yeah, as regards head injury patients are concerned or patients who are unconscious for any reason, the compartment syndrome diagnosis is very likely to be delayed. That is where the role of pressure measurement is concerned. We are fortunate to have that pressure measurement system, but there are very few centers who have that. So a proper clinical examination is the only, if you feel it is tense, then you need to do it. But I don't think we can have anything else, any other diagnostic modality. It is the pressure that will tell you whether it is compartment syndrome or not compartment syndrome.
Repeated
if you have measurement, sorry?
Repeated examination.
Repeated examination. That is important. Repeated examination. And what was the second question?
See, your experience.
Fibulectomy. Yeah. Once upon a time, it had become very common to do a fibulectomy and open all 4 compartments. Over a period of time, many of us have shifted away from that. There are still some people who firmly believe in that, but somehow I am more comfortable by doing a 4 compartment release. There are a couple of reasons for that. Ideally, you need to open all the compartments. Now, the soleus covers a significant portion of the deep compartment, and one has to actually erase the soleus from tibia, and that is when you see the fleshy or muscular portion of deep muscles, and you need to release there. By doing a fibulectomy, which is generally done over of about just 1.5 centimeters, you may partly release the compartment, but you will possibly not release it where it is needed. That is where there is a maximum muscular part of deep compartment. So it is very difficult to release deep compartment. And all in all, people have, as I said, moved away from excision fibula. What about you, Dr. Chandak?
I think, again, The preference is towards double incision compartment release. That is more comfortable. Also, in a patient with fracture scenario, destabilizing the fibula also is not a very good proposition. I think we go ahead with double line. One question.
There was a paper about a single fasciotomy with an anterior lateral incision, where they release anterior lateral compartment, lateral compartment, then open the intraosseous membrane and then go deep. So there has been papers like this, but I personally feel that doing 2 incision, 4 compartment fasciotomy is the safest thing.
Yes.
So both of you conclude the same. It gives an incomplete release.
Yes.
Right.
Fibulectomy gives an incomplete relief and should not be recommended at present as per the current literature.
One more thing Dr. Chandak said is very important to destabilize the situation in a fracture scenario. You take out 1.5 centimeters of inches of fibula, I think you destabilize it significantly.
Then, sir, by going through a single incision and erasing the intraosseous membrane, probably you may endanger the already compromised neurovascular bundle. So
Correct.
it is better not to touch that intraosseous membrane and go for a second incision.
I totally agree with you.
Sir, one interesting point you said is that you are now blessed with one compartment measurement system. So what is the system using, and how do you gain experience on it?
It's a striker machine. And only thing is, as I said, it is essentially for chronic compartment syndrome. Measurement for chronic compartment syndrome. For acute compartment syndrome, we generally do not use it.
It's a clinical diagnosis.
But it's a clinical diagnosis. We have that system. Striker system, which is quite good. It's like a syringe and
measure the pressure compartment.
Measure the pressure.
And who
your
is
experience?
next?
Yes, sir.
Parag, can you share your screen? I think there are no more questions, Chandak, sir.
Yeah, only those 2 questions were there. Yeah.
Is my screen visible, sir?
Yes, yes. And you're audible also.
Yeah. Yeah. So can I start, sir?
Yeah, please go ahead.
Thank you, Maharashtra Orthopaedic Association, for considering me in a veteran surgeon forum. And a lot of knowledge I'm gaining about the compartment syndrome from the senior faculty. So my main aim is to discuss about how to differentiate between the hand and forearm compartment syndrome, when not to release this compartment syndrome, when to release, what to release, and there are other terminologies where we deal in trauma about neurogenic and vascular compartment syndrome. This will be the mainly content of my talk. Here, when we are seeing a patient of forearm involvement and a hand involvement, usually extensor digitorum communis or passive extension of the fingers is painful in a compartment syndrome involved because of the forearm etiology, especially in the hand. When there is a flexion of the IP digit is painful, then the hand involvement is more. Of course, the passive extension of IP digit also can lead to a sign syndrome in the hand, but these are the first 2 distinguishing features. Another thing is, when there is a forearm involvement, usually we have intrinsic plus hand, where the MCP joints are in flexion and IP joints are maybe in flexion, but they may be in extension. But MCP joint are in always flexion in forearm involvement, and in intrinsic and hand, it is always an intrinsic minus hand, where it's like a clawing. MCP goes in extension and IP joint goes in flexion. Then there is a tenderness and tense compartment felt palpable in the forearm as well as in the palm, and in the hand it is always only in the palm, does not cross the wrist crease mainly. Then in the forearm involvement, usually we see hypoesthesia or paraesthesia in all 5 digits of the pulp, because there is an involvement of ulnar nerve and median nerve both, as well as the component of superficial radial nerve. And then in case of hand, there is usually hypoesthesia and paraesthesia in the ring and little finger only, because deeper tissues are involved more early in the hand, like flexor digitorum profundus, pronator teres, pronator quadratus, and ulnar component. So this is how we differentiate between the hand and forearm compartment. As we have discussed about the compartments in the leg, there are very specific compartments in the forearm and hand as well. The first important compartment is flexor aspect, where we need to release all the flexors, superficial and deep flexors. Then we have extensors in the dorsal aspect of the forearm. Then we have mobile wad of three muscles, brachioradialis, ECRL, and ECRB. So these are the three important compartments in the forearm. And in the hand, there are usually 10 important compartments. There are 4 dorsal interossei. We can approach them from the dorsal incision. I'm going to show a small video clip about how to do a fasciotomy in the hand. Then there are 3 palmar interossei. Then there are on either side thenar muscles and hypothenar muscles. And then there is important muscle is adductor pollicis, where the compartment syndrome is only in the thumb. So these are the important compartments in the hand and forearm. This is the relevant anatomical point. When not to release a compartment syndrome, usually this is the time, more than 24 hours duration, if the patient is presenting to us, then usually a risk of infection and rhabdomyolysis, as we have discussed in last 1 hour, we should not consider a compartment release. And if there is an improvement in pain, paresthesia, and capillary feeling, and the tenseness of the palm or forearm swelling, if it is becoming softer in with gradual serial clinical examination, then reduction in a passive stretch pain, then we can consider observing this patient rather than talking about conserving. And when we see a cause of compartment syndrome is treatable, like a tight plaster, dressing, suture material, or IV extravasation, or largely displaced fractures, then we should, rather than releasing compartment, treat this cause. Now, as we see, so this is the treatable cause of compartment syndrome. Here, we may have to, observe the patient as an outpatient or 24 hours observation, just release the plaster completely, give strong elevation, and observe them from 5 Ps. Usually these patients do not require compartment release if at the time of examining at the first place, if 5 Ps are not disturbed. Now this type of compartment syndrome usually need a urgent fasciotomy. So this is a non-traumatic compartment syndrome where there is a cause of disease is autoimmune disease and IV extravasation. But the same lady had right hand, this kind of hand, and she presented with bilateral hand compartment syndrome. The original diagnosis was autoimmune disorder, and then because of IV extravasation, she developed this. But if you observe the color of both the hands, it is basically because of venous compromise, she was developing a compartment syndrome. On the right side, the tenseness of the palm was definitely less, and there was, it was not early setting of a gangrene. And there was a good SpO2, saturation was more than 90%, the stretch pain was less. So this, in compartment syndrome, I do not use the term conserve, we use the term observe, because more or less they may need compartment release, in future. Now, when to release now compartment syndrome? So when we have unequivocal clinical findings, increasing tissue pressure, and more than or around 6 ischemia time. So where, this is the American guideline for considering a fasciotomy. These are the 4 points. If you see, you must consider urgent fasciotomy. And there is a nice article published by Dr. Led T. Chandra Prakasam. Like, see, if all muscles, usually they retain electrical response up to 3 hours. They may tolerate ischemia up to 4 hours. So irreversible damage in the muscle occurs after 8 hours. And that's why the critical limit for muscles and nerves. Nerves do not tolerate any ischemia more than 4 hours. Within 4 hours or 6 hours, maximum 6 hours, you have to release the compartment. Otherwise, there are chances of intrinsic damage to the vessel, vasa nervosum, for the nerves is definitely, patient is going to have paralysis or anesthesia or a total motor wasting of that particular segment of the nerve. So the critical limit is, apart from the skin condition, is decided based on muscle and nerves, as this is the guideline. Now, this is the case where a patient had a blunt trauma due to hit on a pole while traveling in a local train. He did not follow a simple elevation. We have discussed the 5 Ps. You see the pallor at the pulp of all the 5 digits, see a significant swelling, non-hemorrhagic blisters. So this case requires at any cost urgent fasciotomy. So this is called adequate fasciotomy, where on the volar aspect, the fasciotomy has begun from mid-palm, crossing the carpal tunnel and doing the complete carpal tunnel release and releasing the distal up to mid-forearm, all forearm flexors. Then we have released the adductor compartment of the thumb here. Then we have done a mid-neutral approach and done a individual finger fasciotomy. Then on the dorsum, taken 2 incisions to release the dorsal muscle fasciotomy. So this is called adequate fasciotomy in a compartment syndrome of the hand. But in spite of that, patient lost the terminal digital phalanx, even the fasciotomy was done. Now, what to release in hand and forearm? As we have discussed, the dorsal interossei, all 4 dorsal interossei can be approached by 2 incisions, by taking first in the second and third intermetacarpal space and another incision in between 4th and 5th intermetacarpal space. And on the volar side, we have discussed. I would like to show a small video clip about the technique. So, a 5-year-old child had a fall of a cylinder actually on his right hand and presented 8 hours post-injury. And this was the X-ray showing 3rd and 4th metacarpal fracture and a very tense swelling. And stretch pain was present. So all signs of compartment syndrome were present. So how do you consider a fasciotomy? Is consider a longitudinal palmar crease, taking our incision, because of the future scar is also better. Here we are not discussing about the scar. And then we take 2 dorsal incision, one in between 2nd and 3rd intermetacarpal space, another between the 4th and 5th intermetacarpal space. And for the fingers, we take mid-neutral approach and remain little on the dorsal aspect to avoid damage to the digital neurovascular bundle. So this is how we plan the incision. Now, the moment you release a compartment, this has to be done under regional anesthesia. I always do it under proper mid-arm tourniquet, because we have to see a proper muscle. The moment you take incision, now I am feeling the bone on either side and releasing the dorsal interossei, muscle and in the intermetacarpal muscle. This is how you release, and till you feel the bone, and the muscle bulges out, all the hematoma drains out, you have to consider that. Now, this is a classical case of a hand compartment syndrome where the forearm is normal. But I had told the family that if required, I may cross the wrist crease and do the distal forearm release. So the moment you do this and up to the carpal tunnel release, usually the hand remains subtle. This is the 1 week post-op, and usually the child, I never did a secondary closure for for this patient. Usually they do not need it. In 10th, 14th day, they usually all the wound gets healed. Now I was talking about something called neurogenic compartment syndrome. This we see as an orthopedic surgeon more commonly, where we see a distal radius fractures compressing on the median nerve, and patient is having pain and paresthesia in the median nerve distribution. So the moment you reduce such kind of fractures, so the moment you reduce such kind of fracture, look at the soft tissue injury at that level. And this is the median nerve that is seen. It is not ruptured, but it is dent so much, and it is so much displaced on the volar side that the patient has severe pain and paresthesia. But the moment you reduce such kind of fractures in casualty by just doing the traction and close manipulation and just give a slab, their pain reduces. And then once you fix the fracture, usually they have reasonably normal function. Now, this is another case where we see a multiple metacarpal fracture and a thumb metacarpal base fracture. And here I usually fix the fracture at the time of compartment release. But the moment I fix the fracture and release the compartment, in special situation where I know the soft tissue is reasonably soft now and There is no tightness on the compartment. I take some of the tack sutures and I may close some of the wounds primarily, where I am very sure about, the patient is not going to have further consequences. But if somebody do not see such cases commonly, the dictum is do not close these wounds on primary sitting. You have to be very sure about what you're doing. Even if you do it after some time, it is fine. The compartment syndrome also occurs in the finger. Please beware of it, especially in avulsion fractures of the flexor tendon like FDP avulsion, where the patient does not show to the doctor immediately because the only single digit is involved. They do not follow a strict elevation protocol, and they may really cause a compartment syndrome in the hand. So the picture on my right side is showing where exactly we should do a compartment release. I told you that we should do the compartment release in the mid-neutral approach, but here the picture is showing actually that we should do a release at the collateral level and at the Cleland's ligament level. It is very impossible to distinguish a proper Cleland ligament and a Grayson ligament. If you just follow at the mid-neutral line, if you remain little on the dorsal side, the injury to the digital neurovascular bundle can be prevented. Now, this was the case which I showed in my earlier slide, that whenever we are seeing non-traumatic hand compartment syndrome, whatever may be the cause, please have proper counseling with the patient's family regarding she may lose a hand at some point of time. She may require multiple procedures to save the limb. She may have amputation at digital level or at metacarpal level or at below elbow level. Now, this patient came to us within 13-14 hours post-IV extravasation with early pre-gangrenous changes, where the discussion was whether to save the hand or we should offer a amputation. But as she had involvement on the both sides, and the line of, if you see the palmar aspect was much, looking vascular, we offered them a fasciotomy, but ultimately, this patient developed a gangrene. And then if you see the distal forearm level muscles, they started becoming necrosis, and this patient started showing a renal involvement because of rhabdomyolysis. The output was less, the creatinine started rising from normal to 2.3, and then on day 4, we did a below elbow amputation for this patient. So the take home message is, first of all, release whenever in doubt, then solve the treatable cause first, like a tight dressing, plaster, or reduce the fracture. You solve that problem first. Whenever you are talking about releasing a compartment, it is not only a fascia, it is the epimysium over that particular muscle has to be also released. You have to look for the the median nerve and ulnar nerve, and decompress the nerves, especially at the wrist and distal forearm levels. Explain about secondary procedures like, closure or a skin grafting or a flap or an amputation, and do not release compartment after 24 hours. Thank you very much. Mind you, it is our social responsibility to prevent a treatable cause. In the entire this 2.5 hour session, I would request delegate that whenever you die, that need of these patients do not change at the time of their arrival. Whatever time they come to the hospital, we have to treat them as early as possible without wasting time in much of the investigations, like Dr. Agashe sir said about Doppler and all. But then they may land up in Volkmann's ischemic contracture, and these are definitely a burden to the society as they do not become called normal, which they could have become. Thank you so much for giving me this opportunity.
Parag, wonderful presentation, wonderful
Thank you.
case illustration. For the first time, I am listening to you and watching your presentation. I congratulate you for your excellent
Thank you, sir.
presentation.
Thank you. Thank you, sir.
Yeah. Really, Parag, we were unaware of a lot of things which you made us aware. Now, tell me one thing, CRPS or the reflex sympathetic dystrophy, is it a part of compartment syndrome or that is a different entity?
So, sir, CRPS usually has 2 types. The number 1 type is CRPS 1, which is in fact a part of compartment syndrome, means a strict elevation where the cause is not known. CRPS type 2 is always a nerve injury. While doing a surgery, if we cause a iatronic damage to any nerve, and if patient has got a paresthesia, tingling, numbness, hypoesthesia, So CRPS 2 is never going to lead into compartment syndrome. But CRPS 1 is severe paresthesia, and usually it is actually called something called chronic compartment syndrome. They don't need a compartment release. Patient will initially first 3 to 4 days will have severe pain, but this pain is definitely will not ask for multiple painkillers. They will be all right with release of dressing, and if you ask them to follow a particular pattern of shoulder to hand exercises to prevent shoulder to hand syndrome. So if you don't, it is not, we don't need a fasciectomy for CRPS, but definitely we need a medical management for CRPS.
Can I ask a question to Parag as well as all the faculty?
Please go ahead, Mandar.
I would like to ask the opinion about limb elevation, especially in upper limb fractures post-op. So what is the protocol which is followed? Do you just give a pillow or do you put a pine stand elevation? Because everyone has slightly different protocols, and what is the scientific evidence behind it?
So first, my protocol is do not use any IV stand, putting a hand on an IV stand. No, we don't need to fall, because at the time of your surgery, if your surgery has exceeded tourniquet time of 2.5 hours or 2 hours, you please keep in mind that this is going. Always understand, if you have large strict hand elevation above your head level, venous return is also important aspect. We always do not want only a arterial inflow, but then if you have very large elevation, the venous return can be compromised and the swelling can be in fact more. So the best simple technique is ask the patient to touch opposite shoulder, and or ask this is the elevation that has to be followed, or above the heart level of that particular patient in standing position. And whenever he is sleeping, lying down position, he has to keep at least 2 pillows and elevation. We do not want complete hand elevation, restricting their shoulder and elbow movement. That is my opinion.
And that is more uncomfortable to keep it also if you keep it on the
True.
above head. So
Yes,
probably
yes.
this is the above heart level is the best, whether you are in standing or lying down position. That is
Yes,
the
sir.
best.
Yeah, I totally agree. I just want to make 2 more points. One is limb elevation in a suspected compartment syndrome is not to be done. It is dangerous to do limb elevation when you have compartment syndrome and you are taking the patient to theater. Don't do that. And number 3, to continue what Parag says, there was a very common thing to do, a bandage like this and connecting it to a IV stand, and that itself used to cause significant constriction here. So that used to be very common. One way of doing it is having a sticking plaster like this and then holding it here, and then you can tie a string to this band. But all in all, as Parag says, it is best to avoid it. Keep it on a couple of pillows.
I remember in residency, there used to be a line of patients who used to be with the pine stand attached to them. Some lines say pine stand. I think that is one thing which I think everyone should know, that it should not be, it is not advisable.
Question to Parag.
Old timers teaching that it was there everywhere when house officer and registrar we used to do that type of elevation.
Yes.
Now it's not required.
Question to Parag. Do you use WAC as a modality in after release of compartment syndrome or after big wounds in the hand?
So in certain cases where non-orthopedic cases, we like this vasculitis patient, if her hand would have survived, which I showed, we had to do amputation because of the renal compromise, this patient would have definitely benefited with WAC dressing. But nowadays the role of WAC in hand up to wrist is definitely very limited. But the compartment syndrome where forearm muscles are involved, where radius ulna fracture causing a compartment syndrome, shaft radius ulna or post supracondylar humerus, where WAC dressings is common. But up to the wrist level, WAC is usually we do not need it.
Okay.
Yes, sir.
do you always release the fingers also at all the times, or because
No,
it is
sir.
if you have a capillary refill there present, so finger decompression may not be needed. Am I right?
Yeah, yeah, it is not. So, but one, if you have a good capillary filling, then other signs of compartment syndrome also, because then may not need a fasciotomy, in fact. But capillary filling, yeah. But then
Established compartment syndrome of hand, when you have
yes,
taken a second, fourth incision and a thinner
yes.
hypothinner release you have done, and it shows a capillary refill. So
Then we should not do it.
yeah, agree.
And always feel the tenseness in the pulp as well as in the entire finger also. So if in doubt, release it. Yeah.
I want to ask the question to all. Have you seen the compartmental syndrome after snake bite?
Yes, sir. Yeah. So usually I have seen 2 cases and they'll end up in amputation, sir. And that also, if the snake bite compartment syndrome, if it is a hemorrhagic venom or a neurogenic snake venom, neurogenic may not need amputation, but hemorrhagic ones, they one patient I had to do a metacarpal level amputation.
Even the post burns are same. Post burns.
Yes, sir. Yes, sir.
Right. Thank you very much, Parag.
Thank you, sir.
We switch on to the foot part of the compartment syndrome, and we have Girish with us. He's sharing his screen.
Thank you, sir. Sir, am I audible, visible?
Yes.
Yes.
Yeah, thank you, Sangeet, sir. Probably I'm the last batsman because the hierarchy-wise, the compartment syndrome is relatively rare in foot and ankle.
After you, there is Venugopal is also there.
It's a coincidence. It's a
Right.
coincidence you are last.
Right, sir. So when Sangeet sir called me 3 weeks back, कि Girish तुमको compartment syndrome of the foot पे बोलना है, तो literally I was searching, and recently I had 3 cases where nothing were done and the patients were presented very late. But when I went in my dictionary, I found many things like which I have treated 3-4 years back, and I got 2 interesting cases which I would like to discuss on the today's in my session. Through these 2 cases, we would retrieve some learning points. What the things I should not have done, and what the things I've done rightly. So basically, he is a 20-year-old male. So is it visible?
Yes, yes, very well.
So yeah, so basically he was a 20-year-old male. He presented to a general physician with the history of twisting foot injury due to the fall from stairs. And he was simply treated for the ankle sprain on the day of injury. But on the same day, he started developing continuous pain, swelling. There was a progressive deformity of the foot, and X-ray was done on the second day morning because the physician said that there is no response to the Zerodol SP and the medication. So you got an X-ray. So he presented to me with this X-ray, which was classically showing a calcaneal fracture, having all the components of the injury. I will not go in detail about the about the type and the fixation of the injury, but this was a routine protocol to get the CT scan of this injury, because the one thing which was in my mind that I need to fix the calcaneal fracture. Foot swelling is obvious. There are all visible parameters: depressed joint line, lateral wall blowout, everything. CT scan was showing the lot of defects in the calcaneum, although it was completely shattered, blown out fracture. But the thing which was in my mind, that I need to go for a fixation because it was swollen, tense, although painful. But I decided that now I'm an expert in foot and ankles. I will go with a minimal invasive sinus tarsi approach. And I have gone through a fixation, which was reasonably okay, achieved all the parameters, was very happy because these are the initial days of my practice. And this is how I did a closure, minimal invasive. But look at the ecchymosis and the foot condition, although it was minimally invasive. So because of the continuous pain and the swelling, tense swelling around the dorsal of the foot, so I evaluated the patient again. I removed all dressings, kept the foot at the level of heart. I avoided the hypotension, had with the close monitoring and the serial examination. But there was continuous pain on the second day of the sinus tarsi surgery. There was increasing pain. As Chandak sir has said, I got a call from the hospital that patient has tried paracetamol, diclofenac, tramadol, everything. And there is a tense swelling in spite of removing all the bandages and all. There was the pain on the passive dorsiflexion of the toes. So I think in foot and ankle, this is a very important sign, the pain or the tenderness to the passive movements of the toes. And it could be the first manifestation of the compartment syndrome in foot and ankle, unlike the other joints and the limb. There was a reduced sensation on the dorsum of the foot, but again, it was very difficult on the second day with the tense foot swelling. That is it reduced or not? But yes, definitely, as compared to the opposite side, it was reduced, and there was the weak pulsation of the dorsalis pedis artery. So I had the feeling of, I'm dealing with something wrong, and the vicious cycle of the compartment syndrome was came in my mind, and I planned the immediate fasciotomy at the midnight, but this is already a second day post-op, third day post-injury. So the two incision which we used to keep on the dorsum of the foot is the incision just medial to the metatarsal and the incision to the long axis of second metatarsal. So through these two dorsal incision, we can decompress the 4 superficial interosseous components, 2 central components. For the lateral and the medial, as such, there are 9 components in the foot. So through these two dorsal incision, we can decompress majority of the foot components except the medial. So, but simultaneously, you have to be very, very precautious about not to have any injury to the superficial peroneal nerve, which is the nerve in your 4th metatarsal incision, and a medial incision where you need to protect the dorsalis pedis artery and the deep peroneal nerve. So these are the 2 important precautions while doing a dorsal incision fasciotomy in the foot. This is how you decompress the interosseous, central, and the deep compartments. For the medial compartment, there is another incision through which you can, which I will show in my next case. But in this case, I put 2 incisions only for dorsal, and I got a very good decompression. And just to avoid the need of the plastic surgery, I've taken the stack sutures on the 4th day because the foot was very much suppressed. The swelling was subsided, and fortunately, on 23rd day with the secondary closure done on the 4th day, I got a good result. But the same patient, when he came in the follow-up, this was the finding which I noted, that there was a persistent swelling on the dorsum of the foot even 6 weeks after the release. There was a sluggish toe movements, and there was a significant hyposthesia on the dorsum of the foot. And finally, like the picture which came in my mind, that this is not a good foot, this is a dysfunctional foot. Although it is 6 weeks time, so some swelling is expected, but sluggish toe movements and the hyposthesia, they were the permanent sign of, the sign of permanent damage by the compartment syndrome. And patient was kept on the physiotherapy, but unfortunately, we couldn't achieve the good toe movements and a return of the sensation. So I think the delayed treatment, it has created a muscle contraction, not exactly claw toe, which Chandak sir has mentioned, but there is a painful insensate neuropathy. There was some other deformities at the level of the mini muscles, which were not clinically manifested. Possibly may require some surgical condition, and this is a dysfunctional foot, which is a source of chronic pain. So what I learned from this case, because this was the initial case of my life, so compartment syndrome should be suspected in everywhere whenever you have any doubt, and don't underestimate the literature. When I read a literature about this case, I came to know that 10% of the calcaneal fracture, it has been reported in the literature, they develop the compartment syndrome, and 10% is not rare. 1 out of 10 calcaneal fracture, you may land up with such kind of complications. So in spite of seeing everything good on the X-ray fixation, my patient was not happy and I have landed with the dysfunctional foot. So strictly no to the open and accidental fixation or the definitive fixation if the suspicion is not clear. I understood that discussing this point with my patient was very helpful, because taking the patient for the surgery, second surgery, third surgery was very difficult because they were not explained on the day one. Urgent fasciotomy is important when you have diagnosed it clinically, as Agashe sir has nicely mentioned. Less role of pressure monitoring, but clinically, if it is tense, pain out of proportion, you need to plan a fasciotomy as early as possible. Unfortunately, there is no study which compare the acute release on or the delayed treatment, which I have done. So comparing the results, these two studies are not available, but you have to be, you have to do the decompression as early as possible. In general principle, you have to avoid the nerve injury and keep ready to involve the plastic surgeon and the vascular surgeon, and strict no shortcut for the stag suturing or early closure. Let's move to the second case, which was a 25-year-old boy. He had a road traffic accident, fall from the bike, twisting injury, painful discoloration of foot and ankle. He was treated first by the bone settler. Unfortunately, some put application was applied. There was a severe pain. Along with that, the visible toe darkening, and when there was a visible toe changes, then they reported to an orthopedic surgeon who called me and said, Girish, dekho ye, what is happening? So when I opened the plaster, everything, slab, put application, I found that the pain was radiating to the toes as well as to the ankle, along with the discoloration. The pulse was weak. Passive stretch was very, very painful. And the thing which came in my mind, it was a compartment. This was clinically having all the components of the compartment syndrome. So relatively, this case was very much easier for me to diagnose and to treat it as early as possible. But in the X-ray, there was a significant Lisfranc fracture dislocation of all the metatarsal, dorsally as well as transversely. So they were creating a tense pressure on probably on all the components, and because of that, there was an urgent need of the fasciotomy. So the same incision which we have discussed, but along with that, one medial incision also. So inside the Shyam, after doing the fasciotomy, this was a picture like all the tarsometatarsal joints were dislocated, and fortunately with these two incisions. So ideal is you have to put an incision just medial to the second metatarsal, and the lateral incision is along the fourth metatarsal. But because there was a Lisfranc injury and I need to go for the future plating, future fixation of the TMT joints, I put an incision on the Lisfranc sides that is directly between the first and the second metatarsal and between third and the fourth metatarsal. But at the same time, you have to reduce all the dislocated joint, because if you just release the fasciotomy, the pressure definitely get released. But because of the constant dislocation of the forefoot over the midfoot, there is a constant pressure of the forefoot structures on the the neurovascular structures. So this is how the finding I achieved. There was a necrosed muscle, extensor digitorum brevis were necrosed, and look at a video here. There was a very bad dislocation of the tarsometatarsal joints. So these were so unstable that even after putting up the finger and achieving the reduction, they were so unstable that I need to put a K-wire at least to get some temporary fixation to avoid the compartmental pressure to rise. And post fasciotomy, the wound remained open for 5 to 6 days. I've seen the wound daily. There were no plaster, loose bandages. There were the constant watch on the toe movements and the vascular, and the need of painkiller were also watched. And fortunately, the patient was doing well. as Chandak sir has said, that immediately after releasing the compartments, the need of the painkillers, they reduces. On the 5th day, we were fortunate to close the wounds, and open reduction interfixation was done through the definitive fixation using plate and screw on 3rd week. This is how the fixation was done, and this is how the patient has nicely recovered. And look at a good outcome when we have done all the things on the right time. So foot is supple, toe movements are almost full, the ankle movements are also all full, and fortunately the patient was doing very good. There were good functional outcome of this patient. So when the treatment is done on time, the learning point again here, there should be the strong suspicion. Fortunately, we done everything on right time. You have to reduce the dislocated joints, the fractures, along with the fasciotomy, which is again a part of releasing a compartment, treating a compartment syndrome. Simultaneously plan a fasciotomy in foot and ankle according to the need of open reduction interfixation, which will require in future. Because if you do a fasciotomy on day 1, and suppose if your need of the incision is little different, you cannot put 2 incisions within 4 to 5 centimeter gap. So this is a common law in foot and ankle, that 2 incisions should not be like within 5 centimeter to avoid the wound complications. So you need to plan while doing the fasciotomy, that what will be my future incision for the open reduction interfixation of the fracture or the dislocations. High velocity Lisfranc can be the potential cause of compartment syndrome, although not mentioned in the literature how much percentage of the Lisfranc will go into compartment. But yes, through this case, we can understand that this could be the cause of compartment syndrome. Thank you.
This wonderful presentation, 2 cases illustration also. In first case, is there possibility that that compartmental syndrome has now behaving like a chronic pain syndrome too?
Yes, sir. So, first, there was a compartment syndrome which was missed by me. The second insult was created by the sinus tarsi incision, which has probably created more pressure and more this thing. Fasciotomy was done on the 3rd day. So because of the delay in the treatment, finally, in spite of doing everything, we have landed with a dysfunctional foot with the chronic pain. And because it has entered in the stage of neuropathy, it is very difficult to treat it without like neurectomy. So this was chronic painful pain.
Does steroid helps in this such type of scenario?
Very, very controversial, sir. Very controversial. But there is some role of the post-compartmental neuropathy, the steroid in post-compartmental neuropathy.
So
thank you, Girish. Thank you very much. Can we move to the next speaker? He's Dr. Venugopal. He's presenting a case. Can you share your screen?
Yes, sir. Am I audible, sir?
yes.
Yeah. Good afternoon, everybody. First, I would like to thank Gadegone sir, Sangeet Gawhale sir, Agashe sir, and Chandak sir to give me an opportunity to present my case. My case is of 30 years male presented with severe pain swelling in the right hand. He had given a history of compression type of injury while he was working in some packaging machine. His hand got accidentally compressed in the same. So this was his clinical photographs. Within 2 hours, he started showing blips. He was having tossing pain. No finger movements were possible to check, and he was not allowing to touch the fingers also. So this was his presentation. This is his pre-op X-ray, AP view. And if you see a normal X-ray of the wrist, there are Goulet line, which are nothing but arc 1, 2, 3. One is the convexity border of the proximal carpal row. Second is the concave border of the proximal carpal row, and third is of the convex border of the capitate and hamate. So here if you see the concentricity of the gluteus arc are disturbed, and capitate overlaps the lunate, and the intercarpal joint spaces are disturbed, and there is fracture of the ulnar styloid process. And the second X-ray what we got was an oblique. We could not give a lateral X-ray because patient was not in a position to give the position for the X-ray. Then I started to think to take a CT scan and see what is happening inside. So this is an index image of the 3D picture. And from that pictures, this one picture of 2D cut shows there is dorsal dislocation of the capitate, and the lunate is in alignment with the radius, which differentiates it from the lunate dislocation. Normally it is a volar type of dislocation lunate, but here the capitate has been dislocated dorsally. So hence it was a case of perilunate dislocation. Now I am thankful to Dr. Sudhir Warrior sir, who had given me the reply on WhatsApp within 20 minutes. I had sent all the images to sir, and sir's reply was it needs urgent decompression, close reduction and pinning, and also advised after procedure apply dorsal plaster slab with fingers in flexion at the MCP joints. Then we took him in OT under block. We had given traction, and to my good fortune, the capitate, lunate, everything got reduced well with traction and volar pressure on the capitate. And then we move ahead with K-wiring of the capitate to lunate, and this was the picture. Then we moved ahead with decompression of the hand, as Parag sir had already told 10, but to just enumerate 4 dorsal, 3 volar intraosseous compartment, thenar compartment, hypothenar, adductor, and the last I would say it was a mid-palm compartment, though it has no muscles, it is taken as the 11th compartment. So we moved ahead with intraosseous decompression. We took an incision over the 2nd and the 4th metacarpal, as Parag sir said. From there we enter the 1st web space, from there 2nd web space, from the incision from the 3rd web space, and from here the 4th web space. This was how we decompress the intraosseous compartment. For the thenar compartment, they advise you take an incision over the junction of the palmar and the dorsal skin on the 1st metacarpal shaft, and from there we can enter into the thenar compartment. Hypothenar similarly on the 5th metacarpal shaft, junction of palmar and dorsal skin, and from there we can enter into the hypothenar compartment. For the adductor compartment, what I had done is I had gone from the 2nd mark from the 2nd metacarpal incision, and then I had gone into depth and decompressed the adductor compartment. And as Parag sir said rightly, that carpal tunnel also should be decompressed. So we had done that decompression too. So this was the immediate post-operative X-ray. We could nicely get the alignment. After the procedure, his pain got relieved, but he started showing clawing of the medial 2 fingers, which were suggestive of ulnar nerve palsy. Then we did an NCV. NCV showed he had a severe right ulnar neuropathy. But my thinking was, since he had just a compression type of injury and there was no mark incision cut was not there, so I thought it to be a just neuropraxic injury, and just we waited for 3 months. And these were the healed incision marks on the dorsal aspect, thenar intraosseous marks, on the volar aspect, carpal tunnel and the thenar marks. And this is the video showing clawing of the medial 2 fingers.
Excellent function.
Thank you, sir. And these are the follow-up X-ray after 5 months. We can note the capitate and lunate are in a alignment, well alignment. And at the end of 5 months, his total recovery of the ulnar finger clawing was seen. These are the incision marks, carpal tunnel release, thenar release. The clawing has been totally gone off, as you can note here. This is after 5 months. And last week he visited me, and these are his X-ray. And there are no, up till now, there are no osteoarthritic changes, since in a perilunate dislocation, OA changes are very much seen. So we are just observing for that. And this is the video after 3 years of follow-up. 1 week back, he had came to me. I had taken a video of that. The wasting which was seen of the intraosseous is now totally gone off. The incision marks. He is doing heavy work. So this was a case of peroneal dislocation with compartment syndrome of hand.
Very good case.
Excellent case. Venugopal, excellent case.
Thank you, sir.
So having
Doctor-
complete recovery of ulnar nerve is really the best result that one can have. And your perilunate dislocation, the wrist function is also really appreciated. Very nice. Excellent function in the wrist.
Dr. Venugopal.
Yes, sir.
So do you give the credit to Dr. Sudhir Warrior or your own surgical skill?
Yeah, I would like to give full credit to Sudhir Warrior, sir. So I replied within 20 minutes. I was not expecting that was Sunday, and sir was he was free. He was not operating, and I got the reply within 20 minutes, and we took to OT within 3 hours of the trauma. I was very lucky.
Okay. Excellent case.
Thank you.
Okay. Now we move to the last part where I'll be giving some review of literature and entity which is very well known. I think sir touched about it, but I would like to speak more about that. That is the chronic exertional compartment syndrome. Now, can I start?
Yes.
Yes, Sangeet,
Yeah.
please.
So
And,
this
related to this related to
Yeah.
this topic, there are two questions also. Yeah. Please go ahead.
okay. Chronic exertional compartment syndrome. It is a undiagnosed condition and can be easily missed whenever we have a lot of patients in our clinic. It's a reversible increase in the pressure within an elastic facial compartment, leading to compromised tissue perfusion and subsequent pain and neurological symptoms. But these symptoms rapidly disappear with rest without permanent sequelae in the affected tissue, as against the acute compartment syndrome, which is usually limb-threatening if not emergently addressed. Now, this can be in the lower limb or it can be in the upper limb. More frequently, it occurs in the lower limb, and it is more often seen in running athletes and military personnel who are involved in marching activities. In the upper limb, it is usually seen in rowers, those who are doing rowing activity, and in professional motorcyclists. What is the cause here of this chronic exertional compartment syndrome? It could be either improper training, limb malalignment, limb length discrepancy, or a particular wrong running technique, or there may be a uncoordinated muscle control. The clinical presentation is very classical, where the pain can be severe in a specific location, usually restricted to a particular compartment during the exercise, and the patient may get paresthesia, numbness, or even transient nerve palsy such as foot drop. This pain predictably becomes worse with increased exercise intensity and duration. The symptoms are usually relieved within minutes to hours of stopping the exercise. Recurrence of symptoms soon after resuming the activity is the most diagnostic of this syndrome. The evaluation needed is, and the workup what is needed is a long-standing severe chronic compartment may exhibit point tenderness and atrophy of the affected compartment. There can be muscle facial herniations like this. These facial defects over the anterolateral lower part of the leg are usually seen at least 4 to 5 times more common as compared to as normal asymptomatic individual. Radiography, bone scintigraphy, MRI, and electromyography have been recommended, but none of them is diagnostic. What is recommended, and I think Dr. Agashe sir also has spoken about this, is a needle manometry, which confirms the diagnosis in this, wherein the pre-exercise pressure is taken, and 1 minute post-exercise pressure is again noted and that if it is in that zone is almost diagnostic of this entity. The differential diagnosis which we must be aware in this entity are these: medial tibial stress syndrome, stress fracture, DVT, peripheral artery disease related claudication, a simple radiculopathy, tendonitis, myositis, popliteal artery syndrome, or there could be oncological etiology where a patient has a throbbing pain and we don't know the cause. Fibromyalgia is also one. And in the upper extremity, more or less the same could be the differential diagnosis. The non-operative management consists of reducing the activities, altering the foot strike pattern, taping, and even injection of Botox. Operative treatment, the fasciotomies, which we have already discussed, either it could be open, a single incision, minimal invasive, percutaneous, endoscopic, or ultrasound guided technique can be used. Compartment specific fasciotomies or fasciotomies of the all compartment. Out of these, traditional open fasciotomy have shown increased success rate compared to the non-operative management. But the drawback of this is almost 75% of the athletes, they return to the normal sports activity after a fasciotomy. But 20% does not experience full resolution of symptoms after normal fasciotomy. And lastly, the military personnel, the success rate of this surgery is only 20%. So one has to be cautious whenever you're dealing with this. The various surgical procedures, the problems related to these are, one is endoscopy assisted compartment release. Good results for anterior and lateral compartment releases are described, but recommended against endoscopic deep posterior compartment release due to the risk of hemorrhage. Single minimal invasive technique, although single minimal incision technique appears to have favorable results, but one of the studies, recent studies, there were 4 nerve injuries and 8 patients had recurrence. So this was about all the entity called chronic compartment syndrome, what you should be aware of. And lastly, I would sum up with a guideline which is based on this paper, which was published in February 2020. This is management of acute compartment syndrome, where they have done an exhaustive literature search of 200 full reviewed articles, and they have come to a conclusion recommending 15 guidelines which are useful for all of us. Depending on that, they have categorized strongly recommended when there were 2 or more high strength studies, recommending that moderate, if one single high quality study was available as a moderate strength of that recommendation, a limited recommendation where there were 2 or more low strength studies and they did not allow a recommendation of that particular guideline. And lastly was the consensus, wherein there was no supporting literature evidence, but however, the authors felt that this could be practiced, even though there was no evidence. This was purely based on the clinical opinion. So coming to these guidelines, what are the uses of these biomarkers, which we have spoken about, either the serum or urine, to aid the diagnosis of acute compartment syndrome? The most important is the serum lactate level. It may assist diagnosis of acute compartment syndrome. Serum troponin, limited evidence. Myoglobinuria, again, limited evidence. Biomarkers in late presentations of acute compartment syndrome. These biomarkers do not provide useful information to guide decisions making when considering fasciotomy. This was for the biomarkers. intracompartmental pressure measurement, whether that aids in the diagnosis of acute compartment syndrome. There was a moderate evidence as far as the measurement was concerned. Serial measurement, again, the evidence was moderate. In late presentation, it did not provide useful information to the guide decision making when considering the fasciotomy. What about the recommendation as far as the physical examination to aid diagnosis in this particular category of patients, awake patients and those which are intoxicated, or those who are drug addicts, those who have alcohol abuse, where what was the consensus in these two categories? In awake patients, it had limited evidence supporting the use of clinical examination using serial clinical examination finding to assist is the most important while diagnosing this acute compartment syndrome. In those intoxicated patients or in comatose patients, there was consensus in the absence of reliable evidence. It is opinion of the working group that without a dependable clinical examination or repeated examination or continuous measurements are recommended until acute compartment syndrome is diagnosed or ruled out. And also in these drug addicts and alcoholic who have been lying in a particular position for a long time, one must look for multiple extremity compartment syndrome when you are examining them. Alternative method for the diagnosis, there is a consensus. In the absence of reliable evidence, it is of the opinion, the working group was of the opinion, reported diagnostic modalities like electromyography, infrared spectroscopy, other than direct pressure monitor or clinical examination finding that provide useful information to guide decision making when considering fasciotomy for acute compartment syndrome. So all this have no relevance as an alternative diagnostic method against the clinical examination, which is more useful as discussed earlier. And lastly, these are the other issues which we commonly face. Wound management after fasciotomy. There is a limited evidence to support the use of negative pressure wound therapy. However, our speakers have differed and they recommend that. We'll come to that again. Fasciotomy methods. There is a uniform consensus in the absence of reliable evidence. A fasciotomy technique, either 1 or 2 incision, is less important in achieving, rather than achieving a complete decompression of the compartment of affected extremities. Late or missed acute compartment syndrome, for performing fasciotomy is not indicated. With the evidence of irreversible in-compartment, fasciotomy does not have any role in missed acute compartment syndrome. Fracture management. Surgical fixation, either external or internal, should be performed for initial stabilization of log bone fractures with concomitant acute compartment syndrome fasciotomy. And lastly, neuroaxial pain management, that is giving epidural and or blocks, continuous blocks. Anesthesia may complicate the clinical diagnosis of acute compartment syndrome. Hence, epidural anesthesia must, for a longer time, must not be given in these type of individual or those who are coming to you with acute compartment syndrome. So these are the recommendations in that study, which may be useful to be considered. So that was all about the compartment syndrome, what you should know about. And we are coming to the closure. And before we close, I would like to take a one line concluding message from each one of you on your talk what you had given. We start with Chandak sir.
What I
One
would
concluding.
Yeah. So Sangeet, you very nicely summed up the clinical practice guideline. And what I would like to say is diagnose compartment syndrome, suspect it, diagnose early, release expeditiously, and develop experience with pressure management because it may come to your aid in difficult situations. And use of WAC makes dressing less messier and
Messy, yes.
messier and,
Yeah,
and
yeah.
more comfortable. That's what I like to say.
Right. Girish?
Sir, in foot and ankle particularly, in the fracture situation, like think beyond the fracture, always consider, suspect the compartment syndrome, reduce the fracture, plan the incisions for the future definitive fixation, and definitely not to miss it.
Right. Venugopal?
Suspicion and early treatment is the best option in today's webinar.
Right, right. Parag?
Yeah, it is not only the gangrene that we are always worried about compartment, which may or may not happen, but it is the ischemia to the muscles and nerves, which can happen within 4 to 6 hours. So releasing early to prevent muscle and nerve damage is more important, should be given.
Yeah. And you gave a beautiful message that what by early diagnosis, what we are giving to a society is a different individual.
Correct. Correct, sir. Yeah.
Yeah. Mandar? Unmute yourself.
Remember about the 3 A's, anxiety, apprehension, agitation, and increased analgesic requirement. So increased analgesic requirement is the most important.
Lastly, Agashe sir.
A complete fasciotomy is important. Half-hearted fasciotomy can cause more harm than not doing it.
And lastly, Chandak sir has also given a very important message. A patient who's repeatedly asking for analgesic is the suspicious patient whom you have a slighted doubt of compartment syndrome. If the patient is repeatedly asking you for more analgesics after the surgery, you must suspect that or keep a suspicion in your mind while dealing with those type of patients. And lastly, Gadegone sir, your concluding comments.
Thank you very much all giants in this subject. I also congratulate Dr. Sangeet Gawhale for a wonderful moderation of the subject. I think we have covered each and everything of this compartment syndrome. That is the way we should go ahead with the Veteran Surgeon Forum Masterclass, that the one subject and this dissecting whole things and all points about the that particular subject. It is not possible in a 2.5 hours or 3 year job, but we have done very practical job, practical tips, and senior most consultant Dr. Vikas Agashe has given us a time. I thank you very much. Mandar Agashe, then Parag Lad, Venugopal Chandak sir, and my friend Dr. Girish Motwani, Dr. Abhayankar, and all team of the Maharashtra Orthopaedic Association. Congratulate you for a wonderful webinar, and there is a very good feedback on personal WhatsApp to me that it's a wonderful webinar and great learning. Thank you very much. Thank you.
Right. Thank you very much.
Thank you.
Ashok, can you, with this note, we conclude the webinar. Ashok, can you stop recording? Yeah, thank you, everybody.
Chala. Thank you.
Yeah.
Thank you, sir.
Sorry for my non-connection, poor connection.
Sangeet,
But it,
But it went well after that. No problem.
Sangeet sir, Vikas sir, or Chandak sir,